Namaste and a very warm welcome to everyone. Today, as we come together to commemorate World Preeclampsia Day, we reaffirm our shared commitment to advancing maternal and fetal health through knowledge, collaboration, and innovation. At Quidel Ortho, our vision is simple yet meaningful, enabling healthier pregnancies through timely insights and greater clinical confidence, helping improve outcomes for both mothers and babies. We are privileged to partner with the Society for Maternal Fetal Medicine India for this important initiative. SMFMI, the Society for Maternal Fetal Medicine India, is a leading professional organization dedicated to improving maternal and fetal health through education, research, and collaboration. With a strong focus on high risk pregnancies and evidence based care, SMFMI brings together experts committed to advancing better outcomes for mothers and babies across India. We warmly welcome all delegates to what promises to be an enriching and insightful session. And thank you for joining us today. To begin the proceedings, it is now our pleasure to invite Dr. Snehal and Dr. Gayatri, who will introduce and take us through part A of the program. It is our privilege to introduce Dr. Snehal, an accomplished expert in maternal fetal medicine and reproductive medicine with vast experience in high risk obstetrics and fertility care, a passionate clinician, educator, and advocate for women's health. It is our pleasure to introduce Dr. Gayatri, a respected clinician and expert in high risk obstetrics and infertility, currently serving as a consultant at Shamla Nursing Home, Trichy, an executive member of TRIOX and contributor to medical literature. Dr. Gayatri brings valuable clinical and academic expertise to today's session. Over to you, doctors.
Good morning, everyone, and a very warm welcome to Vidya Prabodha, Awakening Through Knowledge, a landmark global awareness and education initiative under the umbrella of the Society of Maternal Fetal Medicine, India, through its flagship initiatives, PENI, Pre-Eclampsia Education of the Nation, India, and Suraksha P. Today, on 22nd May, World Pre-Eclampsia Day, we gather here with a shared global commitment towards improving awareness, early recognition, timely intervention, and equitable care in hypertensive disorders of pregnancy. The theme, Awakening Through Knowledge, beautifully reflects the vision of this initiative, bridging evidence-based maternal health care with community empowerment. Because in preeclampsia, awareness is not just education. Awareness can save two lives at once. Preeclampsia continues to challenge us clinically, socially, and economically. Yet, it also reminds us that sometimes the most powerful intervention begins with something as simple as timely blood pressure screening, preparedness, and informed actions. Today's program brings together distinguished national and international experts, healthcare providers, researchers, patient advocates, and global support groups from India, USA, Africa, and beyond, creating a truly collaborative platform for science, dialogue, and a meaningful change. In view of global participation of faculties in today's webinar from different time zones, it's a beautiful blend of recorded and live version. And we will explore evolving biomarker-based surveillance strategies, socio-economic realities, multidisciplinary approaches, and patient-centered perspectives essential for improving maternal and neonatal outcomes worldwide. And importantly, this initiative has been made accessible free of charge to delegates globally, reinforcing inclusivity, knowledge sharing, and the collective spirit of safer motherhood across the nations. As a coordinator of SIG, hypertensive disorders of pregnancy, preeclampsia, SMFMI, it gives me immense pleasure to warmly welcome all our esteemed faculty members, editors, authors, clinicians, trainees, delegates, and participants joining us from across the world. And I would also like to express our sincere gratitude to our knowledge partner, Quiddle Ortho, for supporting this meaningful academic initiative and contributing towards advancing maternal health care education and awareness. We hope that Vidya Prabodha will not only spread knowledge but also inspire action, collaboration, and stronger systems of care for mothers and babies everywhere. Thank you once again, and let us begin this enriching academic journey together. And now I am going to invite Dr. Prakash Mehta for welcome address. He is President, SMFMI, Co-Chair India, Penai, Chief Division of Maternal Fetal Medicine, and Head of Department of Obstetrics and Gynecology, Bhagwan Mahavir Jain Hospital, Bangalore. And over to you, sir, for your presentation.
Good morning, everyone. Thank you, Dr. Snehal, for welcoming everybody and introducing the speakers. Today's program has been jointly developed by the Special Interest Group of SMFMI for Preeclampsia and the Special Community and Awareness Advancement Group, Suraksha. Now, ancient India was always known for its maternal and fetal protection practices. There's a lovely shloka which says, Ehayehi Bhagwan Brahmanaha Prabhakarta Prajapate Paragroniva Balim Cha Imam Apatyam Rakshana Garbinyaha. That means, O Lord Brahma, the Creator, please accept this offering and protect this pregnant lady from all dangers. So that is what India is. Not now. These are all slokas more than thousands of years old. So a warm welcome to all of you gathered here for this special community program on the Preeclampsia Day. It is indeed a pleasure to see the patients, family members, healthcare professionals, community supporters gathered here today. Your presence shows our shared commitment to maternal and child health. Pregnancy is a time of hope and joy, but it also requires careful attention to the health of both the mother and the baby. Preeclampsia is a serious condition that can affect pregnant women, often developing silently through high blood pressure and other complications. Early detection, regular antenatal checkups, community awareness, and timely treatment can save lives and ensure safe motherhood. This program is also special in the sense that it has wide international participation from United States to Australia to Africa and of course India. SMFMI has also brought out a very thoughtful international publication on preeclampsia. Today, we gather not only to celebrate this book, but also appreciate the creative journey, thoughtful editing, and dedication that brings a manuscript to life. Behind every meaningful book is a collaborative effort between the author and the editor, shaping ideas, refining voices, and helping knowledge reach the readers in their best form. We hope today's program will be informative, encouraging, and beneficial to everyone present. Let us work together and raise awareness, support mothers, and build a healthier future for every woman and a family. Once again, a warm welcome to all, and thank you for being a part of this meaningful program. Namaskar.
Thank you so much, sir. Thank you for this wonderful start of this academic feast. And now I will call upon Dr. Revati S. Rajan to give us overview about the program. She is Secretary SMFMI and Global Co-Chair ISHIP, Co-Chair India Penai, Chief Consultant Maternal Fetal Medicine and Managing Director Mirror Health, Bangalore. Over to you, madam.
Thank you so much, Snehal, for that wonderful introduction. And thank you so much, sir, for getting us, giving us all the momentum that we need. Yeah, so can we just play the slides? Yeah. So this is a great program that we envisioned, I think, for several years now, because we've been working for Penai for almost 5 years. And I'm so glad that we were able to get both the providers and patients and their families on a single platform today, and that too, which can be accessed globally. Now, Vidya Prabodha in Sanskrit means awakening through knowledge. So, a very, very indigenous feeling for this global program. It's a landmark global awareness and education initiative by the Society for Maternal Fetal Medicine India through the Pre-Eclampsia Education of the Nation India project, as well as the Suraksha PESIG group. Now, why do we want to do it? Because we want to commemorate the World Preeclampsia Day, which is today on the 22nd of May, 2026. So, I mean, this is commemorated every year, and this kind of added more momentum to get them all together. The idea was to unite global experts, healthcare providers, patient advocates, and support groups to strengthen awareness and action against preeclampsia. And our vision was to bridge evidence-based maternal healthcare with community empowerment, which is very important. If we are innovating, we are researching, it has to be brought into action. And that's what we want to do through Vidya Prabodha. Promote early recognition, timely intervention, and equitable care. So it just doesn't happen from the provider's perspective. It's so important to keep the patients and the families, as well as the survivors, together. The final, or I would say the most important or the penultimate goal, was to transform knowledge into action, which is very, very important for safer pregnancies and a healthier future. Next slide, please. Yes. And the best part of this program is the global impact with all the scientific focus. So the focus is on important initiatives like biomarker-based surveillance, multidisciplinary care, and socio-economic realities, which could influence maternal and neonatal outcomes. And as Sir has already mentioned, we're talking about this big book which has got together about 150 authors from across the world talking about preeclampsia management. We're featuring distinguished experts from India, the United States, Australia, and Africa through scientific deliberations, patient-centered discussions, and collaborative engagement. And why it matters? This is for free global access for delegates worldwide across different time zones and different geographies. It strengthens international collaboration and inclusivity, amplifies patient voices and lived experiences, which are really very important and impactful, reinforces awareness, preparedness, and support systems. So this is a unified global commitment towards safe motherhood worldwide. And I would also want to inform you that we've got Vidya Prabodha link on the ISHIP website, which is the world body which sets guidelines for management of hypertensive disorders in pregnancy. So this can be reached out by people from across the globe, and the recorded version is going to be available for access as well. And we are so happy to have India on the world map. Next slide, please. Yes. So this is about the book. So we are going to have an extensive discussion about how and why the book was made. I mean, it's really wonderful to say that we're going to have this book encompasses 150 authors from 5 different countries across the globe. And all of this concentrating on implementational science. So this is something that we are going to talk through the program, and we are also going to talk a lot about how advocacy groups and support organizations can translate evidence-based information into meaningful knowledge that can be implemented for optimizing maternal and perinatal outcomes. Next slide, please. So this is our correspondence details. So you can access us or you can email us at smfmi2017@gmail.com. You can access us at smfmi.com. You can contact us. You can follow us. Next slide, please. Yes, so you can like and share our posts on Facebook as well as Instagram as well. So I'm with all this, I'm just leaving the stage to our wonderful coordinators, Dr. Snehal and Dr. Gayatri, as well as Dr. Aishwarya, as well as Dr. Sangeeta, who will take us up through the program to know more about what is in store for us. Thank you.
Thank you very much, Revati Madam, for that introduction of the program to all of us in a clear and splendid way. With this, we move on to the next. Let me take the pleasure of introducing Dr. Sadhana Gupta, who is a convener in the Special Interest Group Suraksha, ICOG Vice Chair 2026, Director and Senior Consultant of Obstetrics and Gynecology in Jeevan Multi-Speciality Hospital and Research Center, and also a trustee in Jeevan Jyoti Trust and Paramedical Institute, Gorakhpur, India. Over to a video from her.
A very good morning to all of you. And it's a great pleasure that we are together on the World Preeclampsia Day under the aegis of Maternal Fetal Medicine Society of India, Indian chapter. And I'm going to deal with socio-economical, cultural aspect and how they influence the management of hypertensive disorder of pregnancy and preeclampsia, with a special note on Indian perspective. Are statistics, data, science is neutral, or they reflect people, regions, religions, and world, from science to politics and economics? Do data mirror our past, present, and future of health system as well as socio-cultural, economic trends and minds? This is a question now before science and the technology, and we need to remember that study of disease is really a study of people and their environment. Preeclampsia, there is a difference, huge difference in the regional magnitude, and the recent studies and the systemic review highly emphasize from the study of 143 countries, and which says that the African region have the highest incidence of HDP, Eastern Mediterranean region has the lowest incidence, European intermediate rates, and American regions have the varying rates of the HDP. The important point to emphasize is that the high-income countries had more studies of higher methodological quality than lower middle-income countries. And that is something we need to understand. What are the economic, what are the technical reasons behind it? And there is a considerable variability in HDP prevalence and study quality across country and the region. And why these are there? There is variation in screening methods, diagnostic protocols, data availability, and we need to fulfill a lot of critical gaps in the low resource setting. In India, the prevalence of hypertensive disorder of pregnancy is 11%. That is one of the highest global rates. And additionally, the South Asian account for 25% of world population, but they carry 60% of global burden of the cardiovascular disease. As it is, we have higher incidence of chronic hypertension as well as the diabetes mellitus in non-pregnant women. And the very, very important point of concern is that the maternal mortality rate is much high in South Asia and Sub-Saharan Africa and the low middle income countries, what it is being called. And the most such maternal deaths are preventable. And we need to obtain a holistic view that how HDP develop, how we can effectively implement prevention and intervention strategies. And the understanding of socio-economic and cultural factor is one of the important part of these intervention strategies. So there is a lot of socio-cultural drivers in HDP which are poorly understood. And we have a lot of insight into molecular genetics, molecular levels, and the biomarkers and the precision medicine. But the socio-economical cultural barriers remain poorly understood, and that is the challenge of today's humanity. The ethnic disparities in HDP are well described, and there is a lot of complex interplay between biological, environmental, socio-cultural, and healthcare factors. And the recent study, which has been published in 2025, which presents the challenges of utilizing ethnicity as a risk factor and suggest action needed to tackle the ethnic disparity. So we all know that the higher incidence of hypertensive disorder and pregnancy in Black women and high criticality as well. But we need to understand that it is a biological science or it is an environmental and the socio-cultural issue. Let's go quickly to the African continent, where a very good study published in the BMC 2024 says that there is high incidence of pregnancy-induced hypertension, and the wealth index and the gestational age and the pre-pregnancy BMI is one of the important pre-existing risk factors. The study highlights the link between socioeconomic status and maternal health, and we need to have the intervention strategy which focus on socioeconomic factors as well as the public health initiative so that we can reduce the maternal health disparities. Again, the study from the Ghana which shows that there is a significant gap in the biomedical understanding, and the woman says that the hypertension is due to emotional stress or due to spiritual cause, and they do attend the antenatal clinic, but there is an inconsistent health education during visit. So their antenatal visit is underutilized, and the healthcare worker failed to communicate the basic facts of the hypertensive disorder of the pregnancies. Alternative medicine cultural practices. In many countries, the people opt for the alternative medicine, and we need to not to criticize them, but we to understand them and how we can adopt the culturally competent approach to maternal care and enhance cultural sensitivity. So this is very important that we don't give them the very like a non-respectful attitude to their practice. We must understand so they open up, and it can help bridge the gap in the healthcare management of the hypertensive disorder of the pregnancies. Developed world to have its own issue, and this is a very good important systemic review and meta-analysis study which shows that in developed world like Canada, Australia, and US, the research suggests that indigenous women have higher rate of preeclampsia and HDP, which range from 6.6 to 36%. And likewise, in US, the Indian and Alaskan Native women have the higher rate of preeclampsia, that is 7 to 11%, as compared to 3 to 5% in white population. So this is very important that the marginalized population and the indigenous population have many adverse background and the future problematical health complication. And there are, again, the study emphasized there are gaps in evidence, which is relation to social, economical, and environmental factors. Ongoing colonization, land disposition, abrupt lifestyle change due to forced migration. So the science does not know. It is genetics or epigenetics, and now the world, when it is troubled with a lot of violence and war and systemic races, the presently, which is very peak high in the world, the problem might compound in the management of the preeclampsia and the HDP. So we have to understand people, and when the people don't trust the healthcare person, the healthcare system because of their residential remoteness, language barriers, races, and the lack of access to appropriate services and treatment, and the culturally inappropriate obstetrical care. These are the few gaps, these are the few complexities which reside in human soul and the behavior. It cannot be taught, it cannot be actually tackled. It is right in the like a psyche of the healthcare people and the psyche of the people who are attending the obstetrical care health system. And this is the thing which we have to deal very, very sensitively, and we have to deal with a very, very in a very respectful manner. So like indigenous women or in some culture, they are not going to have the early ANC, and we should not make them feel very inferior that why they are not coming, but rather we should understand them. So low middle income and the high income countries, it is something which is the world has created, and it is a very unfortunate that the all advancement are being considered only in the term of finance and the economy, but actually it is not so. So many low middle income countries face challenges because of the genuine issues, limited access to healthcare services and the inadequate infrastructure, and very costly antenatal care system might not be feasible in many settings. And we need to evolve simple screening and therapeutical tools, and we will discuss that what India has achieved. Again, WHO Global Survey, a recent survey which shows again a lot of factors which can cause the risk factors for the preeclampsia, and the socio-cultural aspect are one of the important factors contributing to that. In India, there is a high magnitude of HDP now contributing to the third major cause to the maternal criticality as well as the maternal mortality. And India has its own challenges. Our country is the country of diversity in the socio-economical culture, geography, food, language, and culture, and we have our own solution. And the utilization of and the standard of antenatal care is very, very important, which can have long-lasting impact on criticality and mortality associated with the hypertensive disorder of pregnancy. These are Indian data, a beautiful paper by Dr. S.T. Ramavati, which shows that there is an association between level of education, family position, and economic status as an indicator for the severity of preeclampsia. And likewise, the paper by the Anumite Alur, which is we published in the BMC 2024, which shows that low socioeconomic strata, lacking community education, lack of knowledge on HDP management and prevention, and lacking of prenatal screening are few contributory factors which can result into the inappropriate management of the preeclampsia. And this is a very robust systematic review, which include around 17 studies. So what India have achieved, the intervention, policy recommendation, they differ between Indian women in India and other part of the world. So Africa has different thing and the Western world has different issue. But India, considering its diversity and the democracy, we are on the very positive note, and we are focusing on optimizing obstetrical care to everyone, universal quality obstetrical care, as well as the respectful maternity care, and how we have done it. So true revolutions are slow and silent, and they demand our transformation. They don't make noise. What we have done for the community level, female empowerment, awareness of possibility of high blood pressure in pregnancy, nutritional improvement, universal nutritional supplement, and birth preparedness. And it is a great pleasure to share this positive journey to all of you. Secret of nation health lies in the homes of people, and our national, urban, as well as the rural health mission has done tremendous work since 2 decades. Why do mothers die? It has been the part of our like right from any person who is in medicine, we know these are three delays: recognizing problem, decision to seek care because of lack of decision power by women, finances, transport resources. And the third delay is delayed facilities because of lack of skilled human and the technical resources. Janni Suraksha Yojana, which in English can be translated Maternal Protection Scheme, and the National Rural Health Mission has aimed to intervene very, very strongly at first and the second delay. The community health worker, which is called ASHA, that is accredited social health activist, spread across remotest part of the country. Availability of 108 ambulance, which is not only the road ambulance, we have the water ambulance as well as the drone. And this is a picture you can see the water ambulance which I took when I was in Jorhat, a remote part of the northeast Assam state. JSY, what ASHA does, they track every antenatal woman, they vaccinate every antenatal woman, they check hemoglobin, they check on the growth retardation as well as the blood pressure. We have challenges, administration, maintaining quality of care, referral services. But what we have gained, that is the lesson for the world. Marked rise in institutional delivery, community sensitivity to need of obstetrical care, and it intervene all the challenges of today's public health system, that is power, inequity, and accessibility. And it is one of the largest cash transfer scheme which is given to the mother who is delivering and the woman and the community health worker who bring the woman for the institutional delivery. And world can learn a lot of schemes and lot of issues from this experience of this scheme. We have many welfare scheme, and the women empowerment is the today India's main dynamic and the main core of the development. And we have the Pradhan Mantri Matru Vandana Yojana, Pradhan Mantri Surakshit Matrat Yojana, Poshan Abhiyan, Laksh, and the state supported program in many states like Bhamasha Yojana. And the government has also taken great initiative in improving the infrastructure of country. And we have now a very good road to the remotest part. And we have the free ambulance services at every primary health center. So the policy intervention are also in place. We have the risk approach and the operationalizing the first referral unit where the cesarean section and the initial emergency treatment for the preeclampsia and eclampsia can be given. With lot of effort, the Maxel and the antihypertensive drugs are available. Proper transport protocol are now in the place. And now the India boasts most accessible health facilities with very well-equipped district hospital, medical colleges, a wide availability of private healthcare facilities where care is affordable as well as the personal. And we are also addressing on social and cultural factors, that is the cash incentive and the nutritional support. What professional bodies can do, and it is a great pride to say that our all professional bodies, FOXY, ICOG, Maternal Fetal Medicine Society, Gestosis, FIGO, and the Indian Academy of Pediatrics, we are on the combined path for improving the maternal and child health care, which include the hypertensive disorder in pregnancy as well. What is our strength? We can impart skill and teaching to peer. We can create educational module, support hand for the clinical auditing for the self-assessment, monitoring support through member bodies, and adopting adjacent rural area for routine as well as emergencies. So the technical assistance, because we are the professional skilled organization, we can harness human resource and setting the standard for quality healthcare and creating center of excellence, which are the role model for the care and organizational champion to promote and propagate quality standard. So right from the center of excellence, a small private setup also is motivated that they provide the quality and the standard healthcare. A few landmark things which we have done, we will like to share. In 2009, when the FOXY president was Dr. Sanjay Gupte, a nationwide preeclampsia and eclampsia registry was made. And in 2011, we came to know that the only 44% of the health facilities were using Maxel. We did a tremendous educational program, and now it is more than 90% use of Maxulf in preeclampsia and the safe use of antihypertensive drug in hypertensive emergencies. Helping Mother Survive, for which I was a part of it when Dr. Hema Devakar was president, we have a low technology but high impactful program and which deal with the how we manage a case of PPH and the preeclampsia and eclampsia. There were around 1,000 programs across the country in different medical college and different OB-GYN society, and that made a real impact. Manyata initiative is again a Foxy-Jipago initiative, and it creates the safe word checklist, and it trains the labor room staff that how you measure blood pressure, how you measure hemoglobin, urine protein, blood sugar, how to give treatment in hypertensive emergencies, and self and peer assessment. And we have reached around more than 2,000 facilities, and now this program is available on the virtual platform on the nominal fee. And we have actually made the change because even a very small village, a nurse who is not even like a well qualified, but she knows that how to give the Maxulf and how to give the treatment in hypertensive emergencies. Kerala Federation of OB-GYN, they revealed the Hawaii mothers die, the confidential inquiry into maternal death and hypertensive complication contribute to the one third of the cause for the maternal mortality. In Kerala, I want to communicate that it is the less than 50 per 100,000 mortality, and they are doing wonderful work. And the KFOG gave the recommendation to the government, and it also questioned that why the non-manufacturing of the alpha-methyl dopa, which was cheaper and effective drug, and we must have the communication between the administration, politics, politician people, insurance companies, and the full documentation of data for the near miss and the maternal mortality. Maternal Fetal Medicine Society, Dr. Prakash Mehta, Dr. Revati are at the helm of the leading the Indian chapter of Maternal Fetal Medicine Society and doing mammoth work with Pan-India PAN-I workshop, learning stations for measuring blood pressure, awareness for biomarker research tool, addressing socio-cultural barrier, Suraksha campaign, why we are here to reach the people and educate people, and the coexistent issue in SDP in preeclampsia, that is anemia, metabolic disorder, and the involvement of young doctor is a very bright and the positive step because they will continue the battle and they will continue take the baton. The Indian chapter of Gestosis have validated the Gestosis score, which can be taken as a simple screening tool for the preeclampsia screening, because biophysical and the biomarker might not be available in the public setting where we have a large number of the patients. But this scoring system, which is a clinical scoring system, when the score is more than 3, we can start the preventive measure, that is low dose aspirin and the calcium. And this has been validated in many studies and working very well. And with the effort of Dr. Sheila Mane, the Karnataka government has adopted this for all PSCs as the preeclampsia screening tool. And now we have the Gestosis app also, so anybody can download it and use it in their clinical practice. Nutritional issues are challenging all over the world because with global economy, there is increasingly high trend of availability of highly processed food with the sedentary physical activity. And in India, high salt and high fat diet has been linked at the individual risk for SDP and the Suraksha campaign. And we all are there so that we have the huge community education program in personal as well as in bus for the right nutrition with the low glycemic and the antioxidant rich food. We have to reach the unreached. So community education is an ongoing process. It goes slowly, but it is effective. And it is very, very important. And we in primary health center, in small societies, we can always host seminar and workshop. And SFM Suraksha program is doing this. And IMA, Rotary Club, ISOPAR, many organizations are emphatically working so that we can reach the unreached. Lack of prenatal SDP screening is important because people might miss the antenatal visit. And what we can do in today's area, that is the reminder call and messages using mobile app and the mobile phone and the entries to telehealth platform, so that we can, even on the telecommunication, can ask what is her blood pressure and what the thing is going on, and when the test or ultrasound is due, she can come. So telemedicine is something which India is using in institution, and it is being considered a very effective tool, and the addressing the socio-economical cultural barrier. The India has a good access to lab now with the highly improved home collection facility in the remotest rural India. With the great effort of all professional bodies, now the concept of obstetrical HDO and ICU is coming up, and the many medical colleges and the teaching institutions now have the separate obstetrical high dependency unit, because when there is a catastrophic complication with preeclampsia, and the expenses of ICU and the expenses of NICU can push families into long-term debt. And the availability of the quality obstetrical HDU with the critical care specialists actually make them empowered, and they are not in the financial problem. And presently, the public health system for MCH is very robust and as well as the accessible. Still, we have a few new challenges in India. That is pregnancy at extreme of age, especially late age conception. A very good use of ART technology, which is good. Then the frozen embryo transfer and the multi-fetal pregnancy, which are related to the severe degree of preeclampsia and the higher incidence of medical comorbidities in these groups or in elderly pregnancy. So we need new tools to tackle these new emerging challenges. And now the ART bill has actually made a very stringent guideline, and we have to work. This is a gap where we have to deal, because in these patients, we have a quite critical and the important, like a critical presentation of the preeclampsia. Mental health issue. Now, globally, the mental health issue is on the rise, and unfortunately, in India, in last 2 decades, we see a gross rise in the mental health issues. And any patient who survived the criticality of SDP and the preeclampsia can have the mental health issue, and it is again the one socio-economical cultural issue which need to be addressed by the healthcare provider. So what is, we have the takeaway, what is the limited research? So we have a lot of research into the genetics, molecule, and the therapeutical issues in the preeclampsia, but still we have less research which talked about the socio-cultural issue. We have to emphasize the number of good quality antenatal visits, and we have to be very sensitive and aware for the culturally appropriate patient education, especially from the tribal people, low socioeconomic people, illiterate people, because when they are not feeling very secure and confident, they don't use the healthcare facilities and lands up into the critical complication. So these are our key priorities. We want the optimizing BP control, and the woman with the lived experience can be our real, what we can say, the star campaigner. We don't need the celebrities who we have to pay. The women who have survived eclampsia, they can be the real educator in the community and the community outreach program. We also need research which examine the complex interaction between biological, behavior, and environmental, socio-cultural, and healthcare system. And one very important thing, that in our research, the marginalized people are involved. All ethnicity, all indigenous population, all tribal population, rural people, they have to be included in our study so that we can avail the benefit of genomic and the personalized medicine. So this is something, few hot points for the today's research. So finally, the preeclampsia and SDP is not only medical disorder, but major socio-economic public health problem. Across the globe, there are inequality. We have now more war, more economic imperialism. The corruption issue in healthcare economics is still, it also impacts our the utilization of healthcare. And we need a compassionate world, open-mindedness, and understanding of every country and region. Instilling confidence in healthcare provider across the region and across the globe is very important. That is the final clause. So health is not merely an issue of doctors and social service and hospital. It is an issue of social justice. Thank you very much. We wish you a very thoughtful World Preeclampsia Day. Thank you very much. A very good morning.
It was really very wonderful session by Dr.
A very
Sadhna.
good morning to all of you.
Yes, and our lots of gratitude to Dr. Sadhna Gupta for giving us detailed perspective about socio-economic aspects influencing the management of preeclampsia in global and especially in the Indian scenario in her video presentation. Now we are moving forward towards very, very interesting part of this webinar. As we know that preeclampsia is one of the most researched yet one of the most unpredictable conditions in obstetrics. Preeclampsia, an enigma unraveled, a global perspective. This is the landmark book by Evangel Publication, not only bringing us together the science from across the globe, but also it connects deeply with clinical realities, especially in countries like India. As you can see on the screen, the beautiful cover page, and you can see the link where the book is available now on Amazon. So today, let us go beyond the pages and hear directly from the minds behind this remarkable work. And we start our interesting panel discussion from vision to insights from the editors and authors. And first, we will hear from one of the global editors of this remarkable book, Dr. Kenneth K. Chain. So can we have his version of about this book? It is truly a privilege to welcome a distinguished global expert who has significantly contributed to the field of obstetric medicine. We are honored to have with us Dr. Kenneth K. Chain, who is the international collaborators for the Society of Maternal and Fetal Medicine India. He is currently the clinical chief of endocrinology, diabetes and metabolism at Beth Israel Deaconess Medical Center, Harvard Medical School, Boston. And he is also affiliated with the renowned Joslin Diabetes Center. He is the immediate past president of the International Society of Obstetric Medicine. Today, we are especially delighted to interact with him in his role as one of the global editors of the remarkable book, Preeclampsia, an Enigma Unraveled, a Global Perspective. Welcome, Dr. Chain, and thank you so much for joining us.
Thank you for a very kind introduction. It's my pleasure to be here.
Thank you, sir. And we'll be starting our questions. And the first question is, as one of the global editors of Preeclampsia and Enigma Unraveled, a Global Perspective, what was your vision while bringing together experts from multiple countries for this project?
Yeah, thank you. So my personal vision, which aligns very well with the rest of the editors, were that we wanted to bring a broad, unbiased, scientifically sound perspective from experts from all over the world, so that this perspective can be easily reproducible and applied to any clinicians that deal with preeclampsia anywhere around the world, whether it be in a developing country or developed country. Mm-hmm. And in the context that at the time I was a president of the International Society of Obstetric Medicine, my personal vision was to, again, use this book to reach as many clinicians from all over the world who have a passion for obstetric medicine as possible.
True, true. So obviously this collaborative science would definitely transform the maternal healthcare globally. And
yes, well, that was certainly our vision, which which to this day still stands, and we're very proud of that.
Yes, yes. Wonderful. And I would like to take you to the next question, where I would like to ask, like, this planning and release of this textbook almost took 2 years, because it involved like 17 sections, 80 chapters, 150 authors, and almost 4 editors. So could you discuss the complexities of this collaboration and coordination involved in managing such a large international academic project?
Oh, certainly. I think the complexities more had to do with the fact that we had so many authors and co-authors, and everybody had different time schedules. And sometimes it was challenging to organize even, Zoom meetings for people from authors from different places around the world. And different people had different timelines. Like, it's not necessary that, everybody was working toward the same timeline, because things come up clinically. People had a lot of other academic and research interests as well. So, it took time. It was challenging, but we got there in the end. I've been previously involved with other textbooks that involved perhaps members of the same department who all contributed. It's much easier to do it in that context. But again, yes, there were challenges, but we were very proud that we got there in the end. And and I think the finished product speaks for itself, that we had such a wide, broad perspective from so many people from around the world, that we feel that we did achieve our initial mission of getting experts from all around the world to reach to make this book as far-reaching as possible.
True, true. I mean, it's truly incredible to have such a huge synchronization, and I think that's why it is successful today. And so I would like to ask you, you coordinated contributions from the authors across the countries. So what unique perspectives and strengths did these global collaborations bring to this textbook?
Yes, so I coordinated authors from a few different countries, and I think the strength was that, that again, any material that we presented is totally unbiased. It was vetted from experts from different countries to ensure that there was consistency, within the material that was presented, and that any evidence that was presented was, again, was backed by science. We felt fairly comfortable and, privileged that, experts from a few different geographic areas were able to contribute to the same chapter. I think it gave the book a lot of, I think it's going to strengthen the reputation of this book.
Yes, yes. So I think lots of diversity of perspectives has given this, medical literature a rich outlook, and of course it is more clinically relevant. And so I would like to ask you, sir, how important is international knowledge sharing in improving the understanding and management of preeclampsia across diverse healthcare settings?
Oh, absolutely. It's very, very important. I mean, as we all know, it's one of the major complications that occur in pregnancy. It's responsible for a lot of maternal morbidity and mortality. And I think it's our mission collectively to improve the outcome of mothers and babies, from this condition. And again, it is it was very important that when we sort of published this book, that any author that's reading it, that whatever is presented speaks true to what they see, and that whatever is being presented does not seem out of line or out of scope. And we wanted, again, to keep everything consistent, that anybody from anywhere around the world could take the material and share this knowledge with anybody that they work with.
Very true, sir. So, from your perspective, what makes this pre-eclampsia and enigma unraveled a global perspective, a unique and valuable resource for clinicians and trainees worldwide?
Yeah. So again, the key word I think is reproducible, that whatever is being presented can be reproduced anywhere in the world, and that it's not seen to be just unique to one particular setting, that anybody from, anywhere, like I said, could be, highly advanced, developed medical setting versus, there'll be some readers of this book who live and work in areas which are, under-resourced. We want the material that's presented to them to be as relevant and applicable to them as of anybody else, so that the overall mission of improving the healthcare of mothers and babies, can be accomplished.
Yes, thank you so much, sir, for sharing these valuable insights with us. Your thoughts beautifully highlight how this collaboration across the countries, specialities, healthcare systems can actually and collectively advance this maternal healthcare worldwide. And definitely it would help us to improve the managements in this pre-eclampsia. And we deeply are grateful for your time, your leadership, and your contribution to the maternal medicine. And thank you once again for being with us today.
Oh, my absolute pleasure. And I want to just, again, congratulate on the Society for Maternal Fetal Medicine of India. I believe it's celebrating its 10th anniversary later this year. And I want to congratulate you all on all the wonderful work that you've done. And it's been an absolute pleasure for me to be part of this journey.
Thank you so much, sir. Thank you. Thank you for this video. So after this global vision, let's now move. It is truly a privilege to Indian perspective. Let's understand what are those Indian perspectives where science meets some of the most diverse maternal healthcare realities in the world. So now we'll move on to questions to the Indian editors. And we have with us Dr. Prakash Mehta, sir. So I would like to ask first question to sir. While the book brings together a global perspective, but how important was it for you to ensure that the Indian realities of preeclampsia, especially challenges related to access, late referrals, or resource variability, was strongly represented in this book?
Snehal, of course, that was very, very important. Any meaningful conversation about pre-eclampsia has to include the reality faced in countries like India, where the burden is very high and the healthcare context is very uneven. A global perspective is valuable only if it reflects the realities on the ground, not just in tertiary academic centers, but also in district hospitals, peripheral clinics, and rural settings where many women seek the care first. A major issue we wanted to emphasize was the 3 delay pattern commonly encountered in medical care. A delay in recognizing danger signs, delay in reaching an appropriate facility, and delay in receiving definitive care even after arrival in an appropriate center. In preeclampsia, where deterioration can be rapid and unpredictable, each of these delays can dramatically worsen maternal and fetal conditions. Many women still present late in the disease. Why does this happen? Because hypertension during pregnancy initially appears deceptively silent. Okay, apart from this, we have, the rigid one-size-fits-all recommendations, which are often unrealistic. We wanted the text to address how clinicians adapt evidence-based care, pragmatically prioritizing stabilization, deciding when transfer is safer than immediate delivery, and using simplified monitoring protocols where resources are constrained. Ensuring that Indian realities are woven throughout the book helped ground the science in lived clinical practice and made the work more relevant to practitioners across diverse healthcare settings, not just in India, but across the globe. Now, at the same time, it was equally important to highlight the strengths and innovations emerging from India. Clinicians here manage extraordinarily complex cases under pressure and often develop pragmatic, scalable approaches that are relevant far beyond India itself. Including those experiences enrich the global dialogue rather than simply adding a regional perspective. Ultimately, ensuring that the book remained clinically honest, globally relevant, and useful to the practitioners working in real world conditions. So that was the whole motive.
Yes. Yes, true, sir. And that is the real strength of this book, where it is more close to the clinical work, and obviously it is more reproducible, as even Dr. Kenneth said. So I would like to ask you, sir, one more question. Like, as an editor, what do you feel are the most critical gaps in the current clinical understanding or practice regarding preeclampsia that this book attempts to address?
Well, as editors, one of our strongest motivations was the recognition that despite decades of research, preeclampsia still remains a condition where major gaps persist between scientific knowledge, bedside practice, and the real world outcomes. The book was designed not simply to summarize existing evidence, but to bridge some of those disconnects. One of the most important gaps is the continued tendency to view preeclampsia primarily as hypertension in pregnancy, rather than as a complex multi-system disorder with heterogeneous pathways and presentation. We wanted the book to emphasize that preeclampsia is fundamentally a disorder involving endothelial dysfunction, placental pathology, inflammatory pathways, vascular maladaptation, and maternal systemic response, not merely blood pressure. A second major gap was early prediction and risk stratification. Although the screening models and biomarkers have advanced considerably, implementation remains inconsistent across the healthcare systems. The book tries to address not only what is scientifically possible, but what is realistically implementable. The variability and the predictability of the disease progression also remains a major clinical challenge. Some patients deteriorate rapidly despite seemingly mild initial findings, while others remain stable much longer than expected. Now, this uncertainty creates an anxiety even among experienced clinicians. The book attempts to address this through deeper discussion of pathophysiology, warning patterns, hemodynamic understanding, and evolving concepts of maternal monitoring. Okay, we also felt there was an insufficient appreciation of the maternal long-term complications of preeclampsia. Historically, obstetric care often viewed delivery as the end point of the disease process. This book attempts to reposition preeclampsia not only as an obstetric emergency, but also as an early marker for future cardiovascular health. And finally, we wanted to address an educational gap. Preeclampsia is often taught in fragmented ways. People are taught about hypertension, people are taught about seizures, about liver dysfunction, about certain syndromes, especially the fetal growth restriction, rather than an interconnected syndrome affecting both immediate and lifelong maternal and fetal health. The book tries to create a more integrated framework that links basic science, clinical management, system challenges, public health realities, and the long-term maternal outcomes in a unified understanding of the disease. So these were the gaps we tried to cover.
Yes, thank you so much, sir. And that, I think, that makes this book very unique and so much guide for the clinicians, because it is along with the vast experience of all the editors and authors, and which is a real clinical experience. Thank you so much for sharing your views, sir. Now I will move on to another Indian editor, Dr. Revati, and I would like to ask you, ma'am, that the little itself, about this book, when we talk about preeclampsia, it is like enigma. So as it is in the title, like, enigma unraveled, it reflects both the complexity and curiosity. So during making of this book, was there any emerging concept or evidence that particularly change your own perspective on preeclampsia?
Yes, Nehal, this is a very important, I think, I would say an introspective question. And it was a lot of learning editing through the book. And what we actually wanted to do as editors, all of us, like what Dr. Prakash Mehta sir and Dr. Kenneth Shen just said, we wanted to make it very, very clinically relevant. It was not just enough if we had the guidelines there. It was not just enough if we had the good practice points there. What we wanted to do is to see how every setting benefited, whether it was the rural perspective, whether it was an urban, semi-urban, or whether it's a medical college, whether it's a private practice, whatever. I mean, we wanted to make sure that everyone has a message which they can probably implement in their own system so as to optimize maternal and perinatal outcomes due to preeclampsia. And on the way, what I actually learned was there was a lot of education around this, which needed to be probably emphasized through this book. So, this book was trying to integrate basic science, translational research and implementational points together. So, what I understood was it was not enough if the providers spoke about it. I mean, we had providers from different parts of the country and the globe, so we had to put them all together. But what we actually have to do is to build this through education and bring together both the providers and the patients in the same volume. And that's a very unique point that we wanted to do as we actually decided to design the book. So we kind of got, I think, the first time ever from, I think, if I can say, from maybe from the South Asian perspective, or I think one of the unique aspects of any book on preeclampsia, we got a patient advocacy organization like the Preeclampsia Foundation to contribute to the book alongside providers. And it was so insightful because it is not just enough, if we throw a clinical guideline, we need to ensure that the patients accept what we are trying to say, how we can actually build the confidence and trust so that that translates into compliance, which can then lead to bettered outcomes. So this is something very unique. We have a book, we have a chapter that kind of led to a chapter by a patient advocacy organization.
Yeah.
To tie this bridge, we had a dedicated chapter on education. We kind of wrote about how preeclampsia education of the nation evolved in India, which is now kind of a beacon of hope for several countries where clinicians want to empower themselves with the most evidence-based information that's occurring every day, through a course format. So we wrote about how we actually kind of got the preeclampsia education of the nation, India, on board in this book. So I think all of this was a special learning experience. And if you actually notice, I mean, if the readers can actually go through the book, every chapter has a special paragraph and key points which kind of highlight the practical aspect and implementational aspect of all the thought processes that go around in that chapter. So it was a great experience trying to put all these authors together, trying to put it in a language that is kind of implementational and relevant, and also trying to put in a patient's perspective. In fact, we had a chapter, this was a collaborative chapter where we had Professor Anne Mary Hennessy, who was the then president of iShip, wrote a chapter along with a patient advocacy leader. Both of them are talking today. I mean, they've sent a recording on how guidelines can impact optimization of care. Guidelines are not just points, they are also patients' perspective as to how they can probably include them, from their perspective so that compliance is bettered and outcomes can be optimized. So, in all these different ways, this book was very special and unique because it kind of got the providers and patients together in a single volume.
Yes, and I think no book has this unique combination, and that's why it is from the core that yes, it's a passion about this topic. And of course, I would like to ask you one more question, that today we are moving from actually reactive obstetrics towards predictive and preventive maternal care. So, how do you see the biomarkers, early screening, and personalized risk assessment shaping the future of preeclampsia in the management of India, preeclampsia management in India?
Absolutely, Snehal. I think this is a very, very relevant question. And I think this is relevant not just from the Indian perspective. I think it's relevant globally because it's important that we spend money on prevention and prediction rather than paying for criticality, because that's going to be a huge expense. And if I'm going to talk from the Indian perspective, it's all the more relevant. I mean, we have millions of women who are dying because of preeclampsia, and we know that preeclampsia is the number one killer of all the women and children right now. I mean, and the fetuses right now. So, what we decided was we definitely integrated these concepts like biomarkers. We wanted to emphasize how biomarkers can be utilized in low middle income settings. It's no longer restricted to only high income groups. In fact, I mean, these biomarkers were licensed for use in India much before, they kind of got approved in the rest of the world. So we can definitely use them. But we should know there's a lot of education that goes around it, because we should know how to use it, how judiciously we must be making use of these tools so that we do not over interpret or under interpret. And that's why this book and the chapter was important. And we were lucky to get none other than Dr. Anant Karumanji, who kind of was the pioneer researcher who kind of found out about the SB1 PLGF. We had Dr. Sarosh Rana contribute to the chapter. I had the privilege of, contributing to the chapter as well. So we also wrote from the global and the Indian perspective. And what we have to really understand is these biomarkers, if available and licensed for use in any country, for example, India, should be used with the correct kind of education so that the clinicians can be empowered to make sure they optimize resources and use them only for those who are probably going to get sick. They could probably, transfer their women at the right time to a tertiary care with all the resources so that they can actually, and this is also beneficial to the families, because in a country like ours, paying for an ICU for a day costs about 15 to 20,000. So if you can judiciously postpone pregnancy, using these kinds of tools, you can avoid unnecessary iatrogenic preterm births. And it's not just the woman, the husband who has to probably give up his job, the children who probably cannot go to school. So I think with these kinds of tools, we can definitely make a huge difference to the socio-economic issues that actually are prevailing in our country. So I think we should move out of urine albumin obstetrics for preeclampsia and go through these tools if available and licensed. I think we have a lot of these patient survivors who are also understand the benefit of this and say proudly, we will use them to make a difference, and a positive difference in optimizing maternal and perinatal outcomes due to preeclampsia in our countries.
True. It gives a real trial system and really necessary, and it throws this book gives us in detail about it. So as we have heard from our Indian editors, I'm going to again come back to them. But before that, let's understand some more insights from authors. For that, over to you, Dr. Gayatri.
Thank you, Revati ma'am. With this, I'd like to introduce the Indian authors who have been a major part in bringing out this book, and we'll talk to them about their experience while authoring for this. We have with us Dr. Ramani Devi, Managing Director, Ramakrishna Medical Center, convener of the Special Interest Group of HTP, member of the SMFM India, Managing Director of Janani Fertility Center, Trichy. Along with her, we have another author with us, Bharti Sharma. Can we have a CP, please? Yeah. And she is also a coordinator in the Special Interest Group, HDP. Assistant Professor in OBG in PGI Chandigarh. Now to Ramani Madam. Good day, Madam. Today, we increasingly recognize that preeclampsia does not just end with delivery. While contributing to this book, how important was it to highlight the long-term cardiovascular and health risks faced by preeclampsia survivors?
Good morning, everybody. It's my proud privilege to be with this team at this time. And I should thank Dr. Prakash Mehta and Dr. Revati for making me a part of this wonderful webinar. So the topic what we have, I have authored along with Dr. Gayatri, I feel that is very important because we as obstetricians think about the maternal and the neonatal health during pregnancy. But what happens beyond that? The long-term complications are much more complicated in a woman who has got preeclamptic lesions. So this, I should say, preeclampsia is a cardiovascular maladaptation that is happening during pregnancy. And every cardiologists and physicians and the consultant should feel preeclampsia or pregnancy is a stress test, which will unmask the later onset complications like non-communicable diseases like diabetes, hypertension, cerebrovascular diseases like stroke, and that cardiovascular maladaptation, it reflects upon the placenta. See, the placenta undergoes atherosclerosis, which is very similar to that of atherosclerotic changes, what we find in that of the coronary vessels. And again, there is increased sensitivity to circulating angiotensin, which will cause more and more of vasoconstriction. And this will have a definite impact upon the maternal and the fetal health. Now, let us see what are all the associations which really think about the long-term complications, like what the American Cardiology Society says, American Heart Association says. So they all now give importance to the risk factors, probably the adverse maternal effects which are seen during the pregnancy as a risk factor for a later onset of cardiac disease. As far as the women are concerned, maybe till menopause, because of the hormonal support, they have slightly a lesser event of cardiovascular event at a later stage. But once when they cross the menopause, the cardiovascular problems are much higher than that what we face in the men. So we need to have some knowledge about these problems. What are the problems they are going to face? And the basic investigations, what we are doing during the antenatal period, that should be extended. And also, we need to educate the women and the background risk of obesity, smoking, and lifestyle modification and control of lipid profile. So it has been studied from various review articles. Chronic hypertension is the most common complication that a woman occurs soon after her delivery. It may be to the extent of 2 to 4-fold increase. Later on, the woman may suffer from ejection fraction preserved congestive heart failure, which is again 4 times higher, and cardiovascular coronary artery disease and stroke are 2 to 4-fold increase. Suppose if the patient has repeated onset of hypertension in the subsequent pregnancy, her complication is going to be much higher. And on the same time, if we are able to pick up the patients who are at high risk of developing hypertension during the index pregnancy by involving various scores like the Gestosis score or right from the history or the high risk factor the woman has, and prophylactically we can give low dose aspirin and higher dose of calcium. Probably that might help to reduce the incidence of very alarming high severe preeclampsia and eclampsia. So I think we need, and again the IUGR that is caused secondary to this of hypertensive diseases, that baby is also at high risk of developing non-communicable disease. So as obstetricians, we have to handle both the mother and the fetus. So we need to study about the long-term complication.
Thank you, ma'am. That was quite elaborate about what is reasoned in the follow-up. Now, with postpartum recovery, that is a condition which is usually remains very under-discussed, under-counseled, and not well looked upon. What would you, ma'am, like to give as a key message for the clinicians to remember regarding this long-term follow-up and as a holistic care after pregnancy?
That's again an excellent question, because as an obstetrician, the moment we deliver, hand over the baby to the neonatologist, we feel our work is done. But it is the window of opportunity every obstetrician has to promote the health of the mothers. So that needs to be understood, and we need to have a definite follow-up. See, there are various guidelines by so many societies like ACOG and the AHA. Everybody says that we need to have a follow-up. So when should be the follow-up? So the most important thing is at the end of the second week, and between the 6 to 8 weeks, we should ask the patient to come back, and again 6 months. And from that time onwards, every year we need to follow up. And at the first initial 5 years are very important. And during each visit, the patient has to have a evaluation of their BMI, height, weight, and her lipid profile, and sugars should be monitored. And if possible, we need, if there is persistent of hypertension, we need to guide them towards the proper either a local physician or a cardiologist if the patient has got associated cardiac problem, and they have to be evaluated regarding the onset of coronary artery disease. And again, now we have come, the FIGO has come out with a beautiful guidelines how to follow up the patient with hypertension in 2023, where they say that it should be a lifelong follow-up by at the end of whatever it is, then up to 5 years, then again 10 years, and then lifelong. Then it has to be depending upon the local protocols. We need to have a follow-up of all these patients, so that we can definitely reduce the incidence of cardiovascular problems at a later stage. For that, every visit we should advise regarding the lifestyle modification, control of diabetes, control of hypertension, and periodic evaluation. So they also say that breastfeeding reduces the incidence of long-term complications to some extent. So we need to advise regarding that also. So these are all the things that what I would like to share with all of you.
Thank you so much, ma'am, for those insights. Dr. Bharati Sharma?
Yes, ma'am. Yes.
Yes, ma'am. From an academic and teaching perspective, how can books like this help your postgraduate students move beyond textbook definitions and truly understand the evolving science of preeclampsia? What do you think, ma'am?
Yes, Dr. Gayatri. Actually, as an academic perspective, this book has covered, as mentioned by Dr. Mehta, Dr. Revti, and our international editor, that it has covered the basic science, pathophysiology with bedside clinical practice, emerging biomarker, changing concept of prevention and prediction, along with that patient education. So it is going to connect a student from molecular mechanism to the maternal and fetal outcome along with clinical decision making. So basically, it is ultimately going to help a student to promote a evidence-based learning and research-oriented thinking, which is essential for our postgraduate students. So this book is definitely going to help them, because it is it is actually covering everything with the latest guidelines, with upcoming research and everything. So it is actually, helping our students to have a better thinking and better outcome of our women and our fetuses and our new babies.
Nice, ma'am. And in a country like India, even a small, simple step like accurate BP measurement, these small things can also really amount to saving lives. How important is proper screening, staff training, and work at the grassroots level, awareness in changing the outcome of preeclampsia?
As we all know, during COVID time also, the hand hygiene was the most important component of everything. Similarly, for blood pressure, accurate BP measurement is the most effective first step in preventing maternal morbidity as well as mortality from preeclampsia. So, proper screening, early identification of high risk pregnancy, for which we require training, proper refresher trainings of our frontline workers. For example, a woman comes with the high BP, as mentioned by Dr. Sadhna. So if our healthcare provider knows that this kind of patient should be managed in level 3 facility, but before referring, she should be knowing how to stabilize a mother, when to give Maxel, what drug to be given, then only shift her to reduce the morbidity and mortality of the patient. So it is very, very important. The accurate BP measurement is the cornerstone, and then comes the role of proper screening, proper prevention and predictive and biomarker. So I think that is the strategy which can help all our mothers to have a better outcome.
Thank you so much, ma'am. We have with us another author, Dr. Shobha Gudi. Madam is professor and head of the department OBG in St. Philomena's Hospital, Bangalore. She's a postgraduate teacher and examiner and a VP elect of South Zone 2027. Ma'am, from your experience, as an academician and also as the vice president elect of the South Zone Foxy, how do you view the nation's preparedness for early recognition and management of preeclampsia in different healthcare settings of India? How do you view it, ma'am?
Yeah, thank you for the question, and thank you very much for inviting me here. Greetings to everyone who has logged in, and my special regards to Dr. Prakash Mehta, and also my congratulations to Revati for doing such seminal work in this field. So I think Foxy has a very central role to play in the early detection of preeclampsia, number one, in the preparedness for, primary, secondary, and tertiary level of preparedness to be understood by every healthcare provider, especially the obstetrician. Also, Foxy has a very key responsibility for, public awareness for this complication of pregnancy, especially because I think women, societies, communities, families, they are not aware that hypertension can strike in pregnancy with such disastrous consequences. They don't understand the disease in entirety because many experiences are very fragmented. They are just told that there it is, and then the woman delivers, goes home, and becomes all right. Complications are never explained in full. So, still, awareness in communities is very lacking, and that is one of the challenges that Foxy has to overcome. I'm very delighted to say that very strong work is happening, and I must bring to the forefront the primary prevention part. Prakash, if you can recall, as when I was chairperson for contraception and family welfare, the birth spacing and adequate, planning, reproductive planning, and to see that preconceptional care and counseling will mitigate the risk factors for hypertension in pregnancy. For example, weight management or pre-existing disease risks can be kind of controlled well. That is one thing. The secondary prevention part, as most other authors have discussed, other dignitaries have discussed, is the early identification of risk. And I think today Justice's score is playing a very important part. I'm very happy to say that governments are adopting, state governments are adopting, because unfortunately no health directive in India can be centrally, driven. It has to be driven at state level. So Karnataka has taken up the Justice's score, both in the public and private sector. I'm happy to say it is a very simple clinical tool, and I think even Dr. Ramani emphasized on that. And we are doing, our own candidate has done thesis in our institution with good result. We are having a better pickup, and we are able to give aspirin prophylaxis to more women after doing the Justice's score. And we are definitely finding at least a later onset of the disease or prevention of the disease. So that is about secondary prevention. Of course, biomarkers have their role. And we would like to say that in this regard of biomarkers, we would like to generate more research. More research also is required for placental pathology in pregnancy affected by hypertension. Placental imaging also is coming up. So these are the newer avenues where Foxy intends to go, and all academic institutions affiliated, all of us who are working, we are also looking at this. The tertiary prevention, of course, is the birth preparedness and the complication readiness message which goes out for high risk pregnancy. And every center has to see that if tertiary level care is not available for women already diagnosed and suffering from complications, better transfer, and as Dr. Ramani said, they should know, and even Bharati said, transfer with adequate safety in good time, completely driven towards maternal and neonatal survival. So this is the tertiary prevention role. The one important thing I wanted to say, I didn't catch Gayatri. One important thing I wanted to say, Gayatri, is
Internet issue. Ma'am, we are unable to hear you.
Gayatri, I think the net is unstable.
Now?
She's back.
Now? Yeah.
Yes.
Yeah.
Yes.
The last message in this question, public awareness, how to build up. Social media connect in other fields are happening, but not for hypertension disease. So we think that role plays can be brought up. Small, Instagram is so kind of catching everyone's attention. Everybody is hooked to such social media platforms, and we can utilize them to promote knowledge about this, to create small role plays of counseling women, or telling them about it, or showing a complication, or explaining with the help of some IEC material or posters, etc. So all that is kind of in the thought process, and also to some extent in the execution form. So these are the ways forward, and there are very many ramifications of this work, and we are trying to match up, and I assure you that we will join hands from whatever project you give us also, and we'll involve you in ours also. So thank you very much for the involvement today. This is my response to this question.
That was a very clear and pointed and going into deeper.
Yeah, Dr. Gayatri, just one statement I would like to make, that Society for Maternal Fetal Medicine through Suraksha has already started all kinds of programs, including on social media, including on ground level. So a lot of work is going on in it.
Okay. Yes.
And you touched upon everything, ma'am, which are important, and we are also looking forward to your vice presidentship, ma'am.
Thank you. Collaborative work is what Foxy believes in.
Can I ask you just one more question,
we will collaborate. Yes, please.
Yes, ma'am. Sure. We should. With only one aim in mind, the common aim: prevent any mishap to our women. Ma'am, one last question. If there is one message you want to give to all the young obstetricians or the providers, any strata, what they should carry into their practice, ma'am, what is that one message be?
I think obstetric risk stratification is very important. I think that is where it all starts. The mind has to get trained so much that we don't miss anything, We have to have a very good history, and we have to have the keen insight that, okay, this woman is going to develop a problem. That goes for HDP and for other complications in pregnancies also. And I think the way one prepares obstetricians today should be different from what it was earlier. That is one thing which I am very convinced, that our teaching has to change a bit towards preventive strategies. It is the era of prevention, and therapies are getting modified so fast that surgical interventions are becoming less and less. So we have to focus on preventive strategies. We have to teach more preventive obstetrics, and the mind has to be tuned for that. And obstetricians or healthcare providers should focus on obstetrics itself and high risk obstetrics itself as a specialization. They should not think of it as by the way. They should not focus on infertility and do it as one side for having a decent earning. I don't think that should be the approach. You have to put your whole and soul into obstetrics. Then only the mind opens up to all possibilities and to better care. And then definitely fewer mothers will die, and we will have better neonatal outcome also. That holds very true for HDP, because we see late diagnosis and we see disastrous consequences even today. And Prakash, I have been involved in maternal death review in the government, the state government reviews also nowadays. And in the audit, I can see very clearly that in the periphery, we are having very late diagnosis. And women are still dying of hypertensive disorders. Actually, hemorrhage has improved because of our interventions, but HTP, still we have to do more work. So anyway, we are prepared for that.
Thank you very much.
Thank you.
Thank you so much, ma'am. It was really powerful message for all young obstetricians and gynecologists. So with this all wonderful insights from all the authors, we have almost we have come to an end segment of this panel discussion. So I would like to say something about this book. So this book reminds us that preeclampsia is not just a disorder to be treated, but it is a condition to be understood earlier, managed better, and followed beyond pregnancy. And perhaps that is how enigma are truly unraveled. And it was really challenging for this book to get 150 authors from 5 different countries and 4 editors to contribute these so many different perspectives, sharing 17 sections and 80 chapters. So it took almost 20 months after its launch, which was announced during iShip 2023, and then it was there was a soft launch in Sydney in 2024, and later official full launch was in SMFMI annual meeting 2024. So it was a big journey. So I would like to ask last concluding remarks to our editors that after investing nearly 2 years into creating this landmark work, if you had to give our audience the one final thought about the future preeclampsia care and maternal health, what would be that one message? So first, I would like to ask Dr. Prakash Mehta sir, and then Dr. Revati madam.
Well, Snehal, if there is one final thought I would leave the audience after nearly 2 years devoted to this book, and also as a person who looks after the critical preeclampsia patients, it is that the future of preeclampsia will depend on whether we are willing to shift from a model of crisis response to one of prediction, prevention, and equity. For too long, preeclampsia has been approached as a complication identified only after symptoms become dangerous. Yet we
Yes.
know that this condition begins silently long before clinical signs appear. That means the future of maternal health care must focus on identifying risks earlier, monitoring patients more intelligently, and intervening before lives are placed in jeopardy. Now, most importantly, I hope this work leaves people with optimism and urgency at the same time. Optimism because science is advancing faster than ever before. Urgency because every day we delay in translating research into practice, families continue to lose mothers, babies, daughters, and partners to a preventable complication. We have a moral commitment to make safe pregnancy a universal standard rather than a privilege. So that would be my final remark to all.
Thank you so much, sir. Then I would like to hear from Dr. Revati madam.
Yes, Nehal, I think Sir has summarized it wonderfully. And I would say it should be no more considered a book. It should be considered a clinical tool. Nowadays, we're calling, we want to call it a clinical tool because it should probably be part of their practice. So it should kind of be guidance, or it could also be evolving information that they can practice every day. So I'm just hoping that this reaches 40,000 obstetrician gynecologists across the country in every library of every medical institution, so that the ultimate aim of this book to empower caregivers is actually supported very well. And I'm sure this dream will come true very shortly. I mean, we're all working towards this. I mean, it's a lot of effort on the way, but yes, this is what we want to do. And the other thing that I want to emphasize is evidence-based medicine can be made popular only through education and empowerment. So that is something that this book will emphasize. It's about a lot of empowerment exercises, like courses like the PENI, which will actually put together all the information that is actually required to make sure that the clinicians do whatever is the most relevant and most implementational in their clinical practice. And collaboration is something that we all have to kind of adopt, which has been emphasized, because we've had collaborative chapters in this book. We've had a person from outside India collaborate with an Indian author. We've had two Indian authors from two different geographies collaborate. So we should probably emphasize more on collaborative efforts, to for the management of preeclampsia or any high risk pregnancy problem as a whole, which will actually make it more holistic. So this is something that I would want to emphasize. Education, collaboration, research, empowerment, and community outreach is something that we kind of emphasized or brought together as a special highlight through this book. Thank you so much, Snehal, for those wonderful reasoning questions, which kind of got us, relive those experiences every single day through the 2 years and beyond. Thank you.
Thank you
So,
so much.
Snail, I would just like to add one point that the Society of Maternal Fetal Medicine believes in doing the actual groundwork. And
Yes,
as a part of it today, we have representation from all over the world,
yes,
including patient advocacy groups from various countries in the world today participating in this program so
Wonderful.
that, we go further. We also have two very important organizations from India participating with us. One is Rotary. The incoming governor, Madam Harini, is there with us, and we are going to have a great liaison with them to spread the awareness across community. And then we have Dr. Ratnamala from Family Planning Association of India, who is also agreed to work with Society for Maternal Fetal Medicine for a lot of groundwork. So it is not that just we sit in the castle or sit in an tertiary care center, but our main aim is to somehow bring down the maternal morbidity and mortality due to preeclampsia.
Correct.
And just to summarize, we have IZOM, which collaborated with Dr.
International.
Kennechen from the International Society of Obstetric Medicine. We had Dr. Paul Gibson, who is the founder secretary of IZOM, who wrote the foreword for us. We also had Dr. Anne Marie Hennessy, who was the then president of iShip. So we also had iShip collaborate somewhere in between. So we had a lot of international organizations apart from the SMFMI who actually got this book to a level that we are trying to discuss today. And I'm just hoping that this results in better outcomes to both patients and
Wonderful.
their babies.
Very
Thank you.
wonderful. Revati, if I may, can I add a little bit about the book? Snehal,
Yes, ma'am.
Prakash? Yeah.
Yes,
With
yes.
your permission. Yeah, because I was told to comment on the book, but I was not asked that question. So, so I thought, because this journey this book has been a journey actually over 2 years, and very correctly described by Snehal that it's a lot of hard work by both the editors and wonderful connect, and then they put a team to sort the final issues. So actually it was a very good authorship experience for most of us, I must say that. Rarely it happens, we are quite left on our own to kind of struggle with the final part of it, but here there was hand holding throughout, and it was actually a pleasure to be a author for this book. I'm delighted that I was able to contribute to the chapter on induction of labor. And when you read the book, I suggest all obstetricians to read the book, especially on the on the birthing part of it and the critical care part of it, and not to be afraid to deliver these women normally, vaginally, and not rush for a cesarean the moment they see preeclampsia, because a lot of input has gone into that, and safe birthing is possible, and not to be afraid. But the saying is very clear: when the going gets tough, the tough get going. So you must become very tough and take care of these women even when they have severe preeclampsia. So this book has helped in capacity building. It has helped in empowerment of obstetrician, and it will continue to do so. And I think that it has a futuristic element in it. It has covered all possible latest innovations, all the latest research. So I don't think you need to update beyond this much, except for the next some years at least. I will not be so kind of radical, but then I must say that it will serve us for a good number of years to come, and then we can look for an update. But wonderful work done, and I'm very proud to be part of this team. Thank you very much. Thank you. Very comprehensive. Thank you.
Thank you. Thank you so much, ma'am.
Thank you.
Thank you. I thank all the editors, authors for being here today and sharing with us deep insights and most importantly about this hard journey behind this book. And that is real, inspiration for all of us. And every obstetrician and gynecologist should have this book along with them. And that's why it is displayed on the screen. The link is there. It's available on Amazon. Whoever wants to order them in a bulk, they can email to SMFMI email, official mail, and definitely they'll get it with the discounted pricing. And we really got wonderful insights, lot many perspectives. And with this, we end this interesting panel and we will move forward in this academic journey. And all this after brainstorming discussion, now I will invite Dr. Revati Madam to take us through the future focus from knowledge to impact. And she will talk about pain biomarkers and purple study. Over to you, Dr. Revati Ma'am.
Thank you so much, Snehal. Can I have the full slide, please? Can I have full screen? It's kind of, can you minimize this a little bit, Rosalie? Rosalie, I'm not able to see it completely. Can I have the whole slide, please?
So you need to adjust in your laptop, Privti. It is seen correctly.
Just a minute, sir.
Till Revati comes in, Rosalie, we'll be able to get in Dr. Ratnamala from the audience group into the panel group, right?
Yes, sir. So if you
Sure.
allow, yeah.
Sure. Thanks.
Yes, perfect. Yes, so we are talking about future focus from knowledge to impact, and I'm actually covering two important projects that are in the pipeline for the SMFMI with respect to the SIG of HDP, that is Special Interest Group on HDP and preeclampsia. Next slide, please. Next slide. Yes. So the first important thing that I would want to talk about is the biomarker implementation education, India and beyond. We are calling it after the success of the preeclampsia education of the nation India project, which kind of had about 6 learning modules covering the basics till the long-term outcomes of preeclampsia. We have something called the PEN biomarkers, and this was based on a nationwide study, a survey that we actually recently conducted, where, there's been a lot of awareness on the biomarkers, but, there has been a request on a dedicated course that can train them for the actual application and implementation aspects of the PEN biomarkers. So this is going to be an SMFMI iShape collaborative initiative, which will probably come out in 2026. Next slide, please. Next slide, please. Yes. So basically, what we want to do is the biomarker implementation education for preeclampsia, which is basically a novel academic initiative. Rosalie, I think I'm having some problem with the screen. I will try to share it on my own. Can I just share it on my own, please? Can I share it on my own?
Yeah. No.
I think that's better.
Make it the full slide, Revati.
Yeah, I'm doing that. Yeah, this is better. So basically, this biomarker implementation education for preeclampsia is a novel academic initiative under the aegis of the Society for Maternal Fetal Medicine India and the International Society for the Study of Hypertension in Pregnancy, the ISHIP. It was conceived following a nationwide survey that we conducted over the last 3 months, through the PENI delegates, the faculty, as well as the associates, who kind of highlighted that there is a high awareness regarding biomarkers for screening and prediction of preeclampsia. Need for structured, clinically oriented education programs. Biomarker is a novel tool, so you need to have a lot of education as to how to use it practically in different settings. And there was also a demand for practical problem solving in real world biomarker application. So this is what the course is going to do. And what is the aim? Aim is to empower clinicians with evidence-based implementation, focused knowledge for optimal biomarker utilization in preeclampsia care. This is very, very important because you can use biomarkers in a high-income country, you can use it in a low-income country, you can use it in an urban setting, you can use it in a rural setting. But how do you optimize your resources based on it needs a lot of education and clinical implementation practice. Yes. So this is going to have a unique academic framework. We're going to have international faculty. This is all based on what we learned from PENI because we had a lot of recorded lectures and that worked very well. So we're going to have international faculty from across the globe who will contribute recorded expert lectures on preeclampsia pathophysiology, which is the basis of why we use biomarkers. Regional implementational experience is very important. How biomarkers are used in the US versus how it is used in Europe to what is happening in India. That's very important. And best practices. Clinical utility and decision-making strategies in preeclamptic patients. Very important because it's unless and until the patients are aware of what we are doing, they are not going to cooperate with this new tool. So how do you counsel them? How do you make them agree? They're going to be illiterate patients, they're going to be literate patients. All this is going to be trained. Key highlights, it's going to be a workshop-based learning model, probably the first of its kind in the world with an iShip collaboration. Recorded expert panel discussions, very important to actually solve clinical problems using biomarkers. Virtual interactive sessions that we're already doing through PENI. So we are going to have an expert answer questions to these empowered delegates when they have problems, when they use it in clinical practice. Biomarker interpretation and practical application, very important. And this we are going to provide through the guidance smfmi at gmail.com. So unless it's an emergency, they can send us their clinical problem based on this biomarker application and we can solve it real time with them. Now, this is going to ultimately concentrate on a comprehensive coverage of all biomarkers currently licensed for use in India. Very, very important. We've got more than one biomarker which is licensed for use. We have the SFIT1 PLGF. We also have the PLGF POC. So how do we use them in different settings? How do we integrate both of them? All this is going to be highlighted. Emerging and evolving biomarkers with future clinical relevance, that is also going to come in because there are a lot of evolving biomarkers, but we have to understand the limitations and how do we use them, in the days to come is also going to be highlighted. So this is going to be PEN biomarkers for you, and we are going to give you a lot of updates about how you can enroll to this course through the SMFMI for a certification. Next slide, please. Okay. I'll just come to the next one. So basically, there are going to be structured assessments with pre-test and post-test evaluations. We are going to have endpoint certification jointly by SMFMI and iShip. All this based on our PENI project learning and a dedicated global academic collaboration focused on evidence-based biomarker utilization, appropriate resource optimization, surveillance of at-risk pregnant mothers, and improving maternal and perinatal outcomes in preeclampsia. So ultimately, what this education should do is to empower clinicians to optimize outcomes. So we feel now that probably this is going to be a scalable educational concept designed to be extrapolated globally with, I'm emphasizing it again, with region-wise customization based on local practice patterns. you can use a biomarker in an absolute rural setting. You can use it in a corporate hospital. How do you do that is what this course will teach you. And resources, protocols, and patient counseling, very important. You need to spend that extra time. You should empower your nurse and your paramedic staff who can help you to counsel how this biomarker can help. So ultimately, we want to bridge science, interpretation, and clinical practice. So we want empowerment through education, which is ultimately the goal of PENAI. So this is about our first project in the pipeline, which is the PEN biomarkers. Moving ahead, we are also looking at a very interesting research study, very relevant from the Indian perspective. We are calling it the PURPLE study under the aegis of the Society for Maternal Fetal Medicine India. PURPLE stands for PLGF POC utilization for risk prediction and longitudinal evaluation of preeclampsia. So what do we want to do with the POC? We want to establish, these are our objectives, a PLGF POC testing as a validated tool for preeclampsia prediction through pan-India sites for recruitment. It's definitely more convenient to have a POC, but can this be validated across the country through all the heterogeneous setups that we have is what we want to do. And we did a survey where there's been an enormous asking for the POC and integration of both the ratio and the POC, which is very, very interesting. Enable precision risk stratification, just like what many of our panelists have suggested. We need to understand precision as to how we risk stratify and early intervention. Optimize resource allocation. I reiterate, optimize resource allocation at every level and improved maternal and fetal outcomes. And also to inform national healthcare policy for biomarker POC-based preeclampsia management. Can you see my slide? Can you see my slide?
No, Revati, your slides are not moving, but it's okay.
And it's not
But there's just one slide. There's just this slide. That's it.
Okay.
There's no, I mean, you can see the purple slide, right?
No,
Purple study slide?
No, sir.
No, it's only the future. The very first slide is there. But it's okay. You have been...
Okay. And the, Rosalie? Okay. So the expected outcomes of
Yeah,
the
ma'am,
purple
you were
study-
calling me out.
Yes, because they were not able to see the slides.
Ma'am, actually, you have to present the slide as the screen.
You have to,
I think if you...
you have to do the
That's
slideshow,
fine.
ma'am.
That's fine. That's fine. The expected outcomes are to reduce maternal and perinatal morbidity and mortality, to improve antenatal care and resource utilization, and enhance national healthcare policy for preeclampsia management. So what do we want to do is to ultimately reduce maternal and perinatal morbidity and mortality with all the results that we get out of this POC exercise. So let's hope that the biomarker course as well as the POC research project will probably empower us more, and we vouch on this World Preeclampsia Day that we will contribute our best to make sure we optimize maternal and perinatal outcomes across the country and beyond. Thank you.
Yeah, thanks, Ray. Just to complete it, the Purple study is going to be a very, very rigorous study. And we are sure that this will be published in one of the, reputed journals. We are sure about that also. And we are going to be multi-institutional study with involving both smaller centers, tertiary care centers, medical college hospitals, and even primary health centers. So we are going to involve everyone and see that, the entire project can be used across all kinds of facilities. Thank you.
Thank you so much, Revati madam and Prakash sir. We are almost at the end of our session that we have designed for the providers. To sum up, let me give a few key takeaway points for everyone who has attended today's webinar. Well, in medical fraternity, all of us, every department, every specialty, and every healthcare workers, we have just a common role and a common responsibility. to reduce mortality and morbidity in the conditions we treat. In other parts, it's okay. But in obstetrics, it becomes even more sensitive as the person or the patient in question is a young woman who has all her dreams and a very bright future with so much to accomplish in front of her. And it is a great tragedy if she's going to lose her life during childbirth. And she's not just a woman. She's a mother, a daughter, a heart of the family, and hope of a child yet to be born. The greatest challenge today continues to be preeclampsia in obstetrics. This disease can suddenly appear, progress rapidly, and devastate mother, fetus, and the doctor who's treating them. Despite all the advances in medicine, preeclampsia still continues to be a major threat to obstetrics, because in most of the world where the developed countries are in question, and countries like India, where the geography is really vast, deliveries take place everywhere, even in remote places where only the trained guys are there, etc., etc. So it becomes very important for us. We have really made great leaps as far as technology is concerned, but the grassroots level, identifying early changes or early signs of developing preeclampsia, recognizing them early, arranging for a transfer, and maybe if the signs are quite severe, simple training methods to stabilize the patient and timely referral can bring down the mortality and morbidity by leaps and bounds. Hence, it is very important for us to go to the grassroots level, and all the peripheral doctors in the primary health centers, or even the guys and the area nurses, ASHA workers, everyone, simple how to take a proper BP, everything will really help us bring down the maternity, because the technology is there. But will the mother reach the technology on time to save herself? And then we have the problem. Childbirth has been happening ever since Adam and Eve were there. So the whole society feel they all know enough about it. And when a woman is actually having a problem, the wrong kind of inputs from the society, her relatives, no, this is nothing, you will have pre-lady-ma in pregnancy, that's quite common. All these wrong informations from the society, from her relatives, is going to further delay her from getting into seeking early care. So it becomes very, very important for us to have a program like Suraksha, where we want to go to the people and teach them. It is their health they have to monitor and maintain. So we have to take them also into our confidence and teach them and make them more responsible. And we all know that as far as preeclampsia is concerned, our book itself says very, very clearly, it's an enigma. The deeper we dig, the deeper it goes. There's so much yet undiagnosed and poorly understood, etc. Hence, future research is a must. This book has been really authored keeping all these things in mind. The vision of the latest relevant information for the clinicians, and how you have to go beyond this so that we are able to conquer more and more of it. Enormous efforts have been put into this by all doctors from all over the globe to include every essential detail. So and in a language which is very, very friendly to everyone, no very complicated languages. So all these things, publishing all these things, educating the providers, educating and sensitizing the patients, these are all going to help us bring down the mortality. The technology is there, but as long as the woman comes and reaches the healthcare facility on time, we can really decrease her mortality, morbidity, prolong the pregnancy as much as possible, so that a better neonatal outcome is also possible to a great extent. And this is never going to be a single. We all know preeclampsia is not just a high BP in pregnancy. It's a multi-system involvement, so much yet to be unraveled, and we definitely need a multidisciplinary team to give the best outcome for the woman in question. So yes, a nurse who's taking a proper and a correct blood pressure, recognizing signs, symptoms, bringing them early. Everybody, an anesthetist who's ready for the emergencies, a neonatologist who's ready to handle the baby in case we need an iatrogenic early delivery. Everyone form the team. It's not an obstetrics problem alone. We all form the team together, and we have to be marching forward together. Sometimes The small awareness can be all it takes to be the difference between life and death. That is the importance of making the grassroots or the peripheral people more aware of what are the signs they have to look for, etc. So, if I have to sum this up, 3 things. We need more research, we need more understanding, we need more predictive measures so that we recognize early, and we have to sensitize people. Point number 2, eyes will not see what the mind does not know. So we will have to tell the people and the providers basic things so that the eyes start looking for them because they now know. And one last thing is, as obstetricians, we have yet another very important responsibility. Pregnancy is going to be that mother's first and best master health checkup. We have a woman with us who's never been to a healthcare facility before. She's healthy, young. So pregnancy is that window through which we are going to look into the woman's future. So more studies and more understanding of the postpartum care or long-term follow-up. During pregnancy, what are the conditions the woman develops? She is at a higher risk of developing those problems in the later life. Why do we want to predict it? So that we have a chance to make wise choices to prevent it, so that a lifestyle changes or something can really help the woman either prevent the onset of the problem or at least delay the onset, so that a healthy mother can be available for a healthy family for the longest part possible. Thank you very much. And I also contributed to the book. And I should really say, I always believe that there is a distinct difference between an author and a teacher. A scholar and a teacher. A scholar is somebody who knows a lot of things, but a teacher is the one who knows how to take it across the table to a student. Thank you, Prakash Mehta sir and Revati madam. You are both of you. It was a real good experience for me also. And I'm very happy to be a part of this, taking our responsibility as obstetricians ahead. And all of us will together take it forward. Thank you very much, team. Snehal, it was fun and a pleasure working with you too. Thank you.
Thank you. Now we will be moving to part B of this wonderful webinar, and over to Quidel team for that.
Thank you, ma'am. I would like to just cross-check if my screen is visible.
Yes, yes.
We now move on to the part B of today's program, dedicated to our patients with a focus on awareness and informed care. It is our pleasure to invite Dr. Aishwarya and Dr. Sangeeta to guide us through this important session. It is our pleasure to introduce Dr. Aishwarya, a dedicated clinician with expertise in women's health and advanced training in minimally invasive gynecology and robotic surgery, an executive committee member of SMFMI and associate consultant at Aster Hospital, Bangalore. Dr. Aishwarya brings both clinical excellence and a strong commitment to maternal health. We are pleased to welcome Dr. Sangeeta, a respected obstetrician and gynecologist, currently serving as a consultant at Cloud9 Hospital, Bangalore. With her dedication to women's health and maternal care, Dr. Sangeeta brings valuable clinical expertise and practical insights to today's patient-focused session. Over to you, doctors.
Thank you. Thank you so much for that introduction. Good morning, everyone, and thank you for joining us today on World Preeclampsia Day. Today is not simply the launch of a program, but it's the beginning of a movement rooted in awareness, education, support, and the belief that no woman should ever feel alone during one of the most vulnerable and important journeys of her life. So it gives me immense pride and hope to officially introduce Suraksha Preeclampsia, the very first formal program under our SIG Suraksha. The word Suraksha means protection, safety, and security, and that is exactly what we hope to create for women and families everywhere. A space where knowledge replaces fear, where awareness leads to earlier action, and where women are empowered not only through medical care but through compassion, community, and a shared experience. So, we are launching Suraksha PE during World Preeclampsia Month because preeclampsia remains one of the most important and yet one of the most misunderstood complications of pregnancy. Across the world, millions of women are affected every year, and it continues to be a major contributor to maternal and newborn illness and mortality. What makes preeclampsia particularly challenging is that it can appear unexpectedly, progress rapidly, and often remain unrecognized until serious complications develop. That is why awareness matters, that's why education matters, and that is why Suraksha matters. Our vision for Suraksha PE is simple but powerful: to create a platform where science, public awareness, patient education, advocacy, and emotional support come together to improve maternal outcomes and strengthen communities. One of the most unique aspects of this initiative is the diversity of voices coming together with a shared purpose. So today's program reflects what Suraksha stands for: bringing together clinicians, patients, advocacy groups, NGOs, and community organizations from all across India and around the world. We're especially proud that Suraksha brings together global expertise with local action, creating opportunities for shared learning, meaningful collaboration, and real impact at the grassroots level. Because maternal health challenges do not recognize geography, specialty, or borders. One of the reasons we created Suraksha was because we recognize something powerful: the extraordinary impact women can have in supporting one another. Clinical care remains absolutely essential, but emotional reassurance, lived experiences, and shared understanding can often become equally powerful, helping women feel informed, supported, and less alone. So, through Suraksha, we hope to create conversations that are honest, educational, and empowering. Conversations that encourage women to seek help early, to ask questions confidently, to recognize warning signs, and to advocate for their own health. Importantly, we also want to change the narrative around preeclampsia. With timely recognition, the right support, and evidence based care, positive outcomes are possible. Suraksha is designed to be a long term platform addressing mental health through multiple approaches. And today, our journey begins with preeclampsia. A key part of this vision is taking education beyond hospitals and academic spaces and into the communities where women live, work, and seek care every day. So, through our collaboration with the Family Planning Association of India, village outreach initiatives, education programs for ASHA workers through our Pen Eye modules, and partnerships with Rotary and community networks, we hope to strengthen awareness at the grassroots level, improve early recognition, support timely referrals, and ultimately create safer maternal outcomes. I also want to acknowledge something deeply important today. Behind every maternal health statistic is a real woman, a real family, and a real story. Sometimes those stories involve fear, sometimes uncertainty, sometimes resilience beyond words, and sometimes extraordinary courage. So, the women who choose to share their experiences through Suraksha are doing something incredibly meaningful. Their voices have the power to help others recognize symptoms earlier, seek care sooner, and understand that they are not alone. Today's program represents the power of collaboration, bringing together expertise, advocacy, lived experience, and community engagement into one conversation with a common goal: healthier mothers, healthier babies, and healthy futures. So, to everyone joining us today from different parts of India and all across the world, thank you for being a part of this beginning. No matter where a woman lives, she deserves awareness, she deserves access to care, she deserves to be heard, and she definitely deserves to feel safe during pregnancy. And that is the future Suraksha hopes to contribute toward. And we hope this initiative becomes not just a program, but a source of support, strength, education, and hope for women and families everywhere. So, thank you all once again for joining us. for supporting this vision, and for helping us take the first step toward creating safer pregnancies, stronger communities, and healthier futures for women everywhere. And there's no better way to bring that mission alive than hearing from experts and advocates working at the forefront of maternal health. So today's panel reflects a spirit of collaboration and shared purpose. With that, let me warmly welcome my colleague Dr. Sangeeta to join me as we begin our panel discussion.
Thank you, Dr. Aishwarya, and thank you for setting the context for today's conversations. Today's discussion brings together leaders and change makers who have each contributed in meaningful ways to improving maternal health outcomes. And I'm honored to introduce our national panelists who will help shape this important conversation. First, we have Rotarian Dr. Harini Ravindranath. She is an alternative medicine practitioner and a distinguished leader in the Rotary International, where she has served for nearly 2 decades under the motto Service Above Self. She has the honor of being elected the first woman district governor for Rotary District 3191 for the year 2027-28. Her work reflects a deep commitment to community service, leadership, and grassroots healthcare outreach. Next, we have Dr. Gayatri Karthik Nagesh, who is a pioneering robotic gynecological surgeon and the first female robotic surgeon in Karnataka. She currently leads the OBG and robotic surgery program at Aster Hospitals, Karnataka, and has previously served as the head of the department and adjunct professor at Mahe and Manipal Hospital, Bangalore. Widely recognized for her contributions to high-risk pregnancy care and surgical innovation, she continues to mentor, teach, and lead clinical research in women's health. Dr. Ratnamala Desai is a professor of obstetrics and gynecology at STM College of Medical Sciences, Dharwad, and a nationally respected voice in reproductive and maternal health. She serves as the national president of the Family Planning Association of India and has worked extensively with international organizations, including IPPF and the Geneva Foundation for Medical Education and Research. Her contributions span policy, education, family planning advocacy, and women's healthcare leadership across India and globally.
Maternal health challenges may look different across settings, but the commitment to safer pregnancies and healthier outcomes is universal. So, to broaden this conversation further, it's my privilege to now introduce our international representatives who bring global expertise, advocacy, and experience to today's Suraksha panel. Ms. Koiba Koilarbi. Ms. Koiba Koilarbi is the Executive Director of Action on Preeclampsia in Ghana and an internationally recognized maternal health advocate. She represents patients' voices across multiple global initiatives, including the WHO Maternal Health Guidelines, the SPOT Impact Study, and the PULSE trial. Her work has earned her recognition as one of Ghana's most outstanding female change makers for her leadership in maternal health advocacy and public engagement. Ms. Eleni Segas is the CEO of the Preeclampsia Foundation and one of the world's leading patient advocates in maternal health. She serves advisory roles with the WHO, the NIH, the NICHE, helping shape global conversations around pregnancy-related health research and policy. A recipient of I-shaped Leon Chelsea Award, her work has had a transformative impact on awareness, research, and patient support in preeclampsia care worldwide. Professor Anne-Marie Hennessy, AM, is an internationally renowned clinician scientist and former president of the International Society for the Study of Hypertension in Pregnancy from 2021 to 2025. She currently serves as the Dean of the School of Medicine and Foundation Chair of Medicine at the Western Sydney University, Australia, and has been widely recognized for her contributions to women's health research and medical education. Joining us today as a patient representative on the panel, she brings a uniquely compassionate and deeply informed perspective to conversations around preeclampsia care and advocacy. Lastly, we have Ms. Amanda Davidson. She's the chair of PEARLS and serves as the director of the Australian Pregnancy Hypertension Foundation Limited. Alongside her work in maternal health advocacy, she is also the CEO and the principal of the Davidson Legal Consulting Advisory. Through her leadership across healthcare and policy spaces, she continues to champion collaborative efforts aimed at improving outcomes for women affected by hypertensive disorders in pregnancy. It is truly a privilege to bring together such accomplished voices on one platform, and we look forward to learning and hearing your experiences and perspectives today. So let us begin. Dr. Sangeeta, I think you're muted.
Sorry. So, what is preeclampsia? Preeclampsia is a potentially life threatening pregnancy complication that can affect any pregnancy and has consequences that extend far beyond delivery if not recognized early. And today's conversation will look at the challenges, the unanswered questions, and opportunities from awareness and diagnosis to decision making, support systems, and caring for women during pregnancy and into the postpartum period. Our first question today is for Dr. Gayatri Karthik. Despite major advances in maternal health care, many women with preeclampsia are still diagnosed late, especially in India and other low and middle income countries. From your experience, ma'am, what are the biggest reasons for this delay?
Good afternoon, everybody. Let me first begin by thanking Dr. Prakash Mehta, Dr. Revati, Dr. Sangeeta, and Dr. Aishwarya for giving me an opportunity to be on this esteemed panel. Preeclampsia.
Dr. Gayatri, if I may interfere for a minute.
Yes, sure.
Yeah, this is one more first today. Dr. Aishwarya, the moderator, is the daughter of our panelist, Dr. Gayatri Nagesh. So this is one of the first in any of the societies or any of the programs.
Thank you very much. It's your blessings that she is where she is. So with regard to the question, see, India is a country, as many other countries in the world, which has a very difficult and a different health system. So we have patients in the rural setup and in the urban setups. And it is basically the lack of awareness. We have greater population in the rural setups. So the first health ground level workers are sometimes not aware of the problems. They also are not capable of sometimes taking the blood pressures correctly. So the problems stem from both patient awareness as well as healthcare professionals' awareness. So the lack of awareness of the warning signs or normalizing the pedal edema, slightly increased blood pressure, is a problem which is the most important thing, I would say, where patient lack of awareness leads to delay in approaching the primary healthcare workers. The healthcare workers also are not always equipped to detect these, even measure blood pressures correctly, and they send. So the full, there is a delay in identifying and then progressing, referring to the higher centers. Now, what happens when they have to refer is that sometimes there is socioeconomic barriers. They are not able to afford going to the higher centers, and there are financial constraints which makes the delay further. And by the time they reach the centers which can at least provide primary care, they are already in either preeclampsia or abruption. So what happens sometimes at the primary health care center levels, they don't have adequate medications to give. They do not have protection and referral ambulances to send them. And so finally, by the time they reach a center that can provide the adequate care, they are already into severe preeclampsia, abruption, and the complications. Many of them do not even realize that it is not just a blood pressure problem, that it involves, it's like a volcano which is simmering and ready to burst into a multi-organ dysfunction.
Yeah, absolutely. I think one of the biggest challenges remains the gap in understanding and awareness around preeclampsia all over, which often leads to delays in recognition, delayed care, and delayed treatment, like you said. So it is important to emphasize that early detection can truly save 2 lives. And that brings me to my next question to you. Managing preeclampsia is not just about treating high blood pressure. It also involves counseling anxious patients and families who may suddenly be facing a life-threatening diagnosis. So what are the biggest communication and counseling challenges that you face as a clinician, and how do you help families navigate fear, uncertainty, and certain difficult decisions?
So when patients come, first of all, they are in a state of anxiety, worry that such a thing has happened. Second, they are not aware of what really the problem is. So one has to be compassionate, understand what their problem is, understand that they need to be handled gently in a language that they can understand. Use simple words, explain to them what the problem is, keeping their anxieties in mind. At the same time, there we need to guide them to a decision that requires to be taken, and you have to explain to them that we need to balance both maternal and fetal health, and maternal health will take priority over fetal health. And if it requires to be if a patient requires to be delivered, she needs to. And the fact that this is not a simple problem that they are having, and that we will require a multidisciplinary team to handle this. And at times, what we resort to is to be sit together as a multidisciplinary team. All of us sit with the patient, the intensivist, the neonatologist, the neurologist, if required, the obstetrician, obviously. All of us sit together, explain to them where the problems are and what all it takes to cure this patient or bring them out. And communication. And the point is that for them, it is something absolutely new. If there was some awareness about these things, they would know primarily that, yeah, these things can happen and we need to take adequate care and reach the doctors early. Well, because that is not happening, they tend to come late. And so you have to give them time as well as tell them that there is an urgency to make decisions soon.
Well, it all stems down to increasing awareness.
Ultimately, it stems to being aware.
Thank you, Dr. Gayatri, for that insightful tightrope walking as a clinician between conveying the urgency as well as still giving the patient and the family time to process what's been explained to them. You touched upon the concepts of informed decision making, which are the cornerstone of evidence-based medicine in the modern day. And I thank you for that. And that reminds us that counseling is not simply sharing information, but also helping women and families understand, prepare, make informed decisions during an overwhelming time. Along that day, like you mentioned, I was so happy that you had said that you require a multidisciplinary team, and that hearing it from multiple resources, including neonatologists, high-risk obstetricians, nutritionists, mental health professionals, having a community support system in place, all of this, how practical would how would this translate practically, and how would this team-based approach look like, and what challenges do you encounter when you coordinate such care? And why do you think that such specialists need to be involved in the care of a woman with preeclampsia?
So one thing is that when they are, first of all, they are overwhelmed by the fact that a patient is in a serious state, and they're suddenly confronted with many doctors, all of them talking in a multidisciplinary center. Sometimes the different doctors may come in at different times, and so they are overwhelmed by the number of doctors coming in and seeing them. And so one needs to explain that the disease is something which is a multi-system involvement, and it is important to handle it globally, comprehensively, and hence it is required to meet so many doctors. And it's important to emphasize that the care plan will be single. It's a joint care plan, and it explained to them that all of us are working for the mother and the baby's benefit. And so that is important to explain to them that it is not just us coming and seeing the baby and the mother alone and treating only blood pressures. The ramifications of the disease that it can involve the liver, the kidneys, the brain, the mental health of the patient. And so it is essential that we handle it smoothly so that the outcome finally is the best possible.
Thank you, Dr. Gayatri. I think you very rightly highlighted how a collaborative and coordinated care, most importantly, can make such a meaningful difference in the management of preeclampsia. At the same time, an important question is how we translate these principles into settings where resources may be limited. So, Dr. Ratnamala Desai, this one is for you. In a rural or a resource limited setting, even small interventions can make a major difference. So, from your experience working at the community level, what are some simple practical measures that could significantly improve early detection and outcomes in preeclampsia?
Good afternoon, everybody. At the outset, I'd like to thank SFM Society for Maternal and Fetal Health for inviting me, and also Suraksha for collaborating with FPI. It'll be a pleasure to work with you. The practical measures that could help, what I understand is that in the periphery is the A&M and the ASHAs who are the primary healthcare providers. There's, for a large population, there's one PHC and one CHC, and these are the field workers who actually go and see the antenatal cases. Now, A&M, I'm glad these days they don't have to carry the big, heavy sphygmomanometers. They have at least the digital BP apparatuses. Of course, ASHAs do not have the BP apparatuses. In some centers, I know the ASHAs also are provided with the BP apparatuses, but A&Ms are provided with BP apparatus, but not ASHAs. So if a simple BP apparatus could be provided and a little education for this ASHA to teach her how to measure the blood pressure, to teach her what is normal and what is outside the range, that will go a long way where she can refer this patient. And also a simple dipstick test where she could detect proteinuria. Now, all these women are, ASHAs particularly, know how to do a urine pregnancy test. It is not difficult for us to teach them how to do dipstick test for proteinuria. So these two simple tests, like recording the blood pressure, knowing the range which is out of range, knowing where it is abnormal, where is the red flag, finding the whether she has proteinuria, these two things will go a long way. And it's not the A&M alone who can do it, because she has got a larger population to cover. But it is ASHAs who can be taught to do these two things, and I'm sure they will do well. Other than that, it's extremely important to create awareness, because many people think that the grandmother in the house will say, okay, I also had pedal edema, it's not a big thing, pedal edema is normal. And many times people ignore the headache, because headache could be due to anything. Headache could be due to mother-in-law irritating her, or the elder children irritating her, and it could be a signal of an imminent eclampsia. So the importance of trying to seek a healthcare worker's advice regarding a headache, getting a blood pressure check. These are very simple, practical things which go a long way in the periphery, because many a time, even in the PHCs, there aren't any doctors available. The doctor in the PHCs loaded with so much of work. He has to do malaria work, he has to do HIV work, he has to do tuberculosis work, he has to see the antenatal cases as well. He or she has to do so much of work in the PHC that he is also overloaded. And many times he or she has to attend so many meetings. So the major responsibility to see the red flag signs should be on the A&M and the ASHAs, where we could train them a little more to pick up these signs.
I'm actually so glad that you said that. I'm sorry, I just want to interject in a little bit. I'm actually really glad that you said that, because these exact two initiatives are something that Suraksha is taking forward in collaboration with the FPI next week. We're planning to train the ASHA workers and teach them about the importance of measuring blood pressure accurately teaching them in a basic manner what preeclampsia is. And also the SMFMI with its SIG Suraksha is planning to give out certain BP apparatuses to them to go out into the field and measure blood pressure, because they're the most in touch with the women who are pregnant. So that is one of our initiatives that we're starting off next week. So I just wanted to put that.
My only thing is that when we give them these blood pressure apparatuses digital, they should see that the battery is working. Many times the batteries aren't working, and also these apparatus should be validated. And I'm extremely happy that we've got rid of the heavy mercury manometers, but they should be validated so that they get a proper reading.
That's a very practical point.
Yes, absolutely.
Thank you, Dr. Ratnamala. People say that when you gift kids toys at the birthday party, also give the battery. I think that applies here as well. You gave really practical and powerful examples of small scale, scalable interventions that can create meaningful change. What is the biggest real world challenge that you feel and that you face while you're working with pregnant women in the community when it comes to preeclampsia?
We have seen that finance is the most important thing for the people living in the community, poor people, farmers, laborers. It's very difficult. Though the government provides free service, it is the person who has to accompany the patient. Now, if a woman is a pregnant woman, a lady will accompany her, and a male attender will come with them. It's the access. The center may be far off. It's the transport. They don't get proper transport. They don't get a timely ambulance. And then it's the money which is required for them to reach the hospital. And it also adds to their negative balance because of loss of work, loss of pay for that day. Because most of these people are daily wage earners, and then they lose their wages. So these are the practical problems these people face, and also certain cultural beliefs like, okay, pedal edema is normal, headache is nothing, you're simply complaining of headache, you don't want to do work. The mother-in-law will tell you don't want to do work, that's why you're complaining of headache. So these are some cultural problems which are there, where I think it's not only important to educate the mother or the would-be mother, it's also important to educate the mother-in-law and husband that these are the things which are warning signals, and you have to bring them to the hospital. Because most of the time, see, you and me we are lucky people living in the cities, we are all independent. But a woman in the periphery, a woman in a village is totally dependent on the decision. She's not the decision maker. The decision maker is the mother-in-law or the husband, and they are totally dependent on them, and the decision makers are the mother-in-law and the husband. So I think it's time that we also educate the mother-in-law and the husband regarding the warning signal, include them in the counseling. What I do is when I see a OPD patient, I don't talk to her alone. I call her husband, I call her mother-in-law and tell them also, give a protein diet, give her salt restriction, bring her for a BP apparatus, because they are the ones who are going to make the decision. Unless they understand the seriousness, this cultural problems, this cultural barrier will not go away.
I think you brought about a very valid point. I think education is not just for the women and the healthcare workers, but also for their families as well, absolutely. But now that brings us to think that maybe reaching women early requires us to think beyond traditional healthcare models and exploring ways, and whether we can explore ways to extend knowledge and support directly into communities. So that brings us to the role of technology and whether this can help close the gaps at scale. So, with increasing access to mobile technology and virtual platforms, do you think that large scale tele-education or even teleconsultations, especially for ASHA workers and rural doctors, pregnant women, can help improve early recognition and management of preeclampsia in the underserved areas?
Yeah, I think nowadays our Ashas are fairly smart, they all use smartphones and they send WhatsApp messages. So they are getting smarter, and tele-education and teleconsultation should happen because they are in the community and they are widespread, and it is going to be difficult to get all of them together and try to educate them. We do see them in monthly meetings. In fact, a week ago, we had pre-eclampsia month we celebrated, and we called all the ashas, and you must see the type of questions these asha workers ask. They are interested, they are curious. So it is very important that we engage them. we take them in confidence and teach them and create awareness, and they will do good work. So it is not only in person we can teach them, but we can also teach them online. We can make a online group and teach them in small groups. And also we can have a teleconsultation. In fact, FPI is working on teleconsultation model where even the paid clients can talk to us on the phone and get their problem solved. And this will be go a long way. But also it's important that we appreciate their work. Ashas, when you have when you have recognized a preeclampsia, when you brought them to the hospital, you have saved this life of this mother and you have saved the life of the child. So when you appreciate them, just simple two words is an incentive for her to do more. So appreciation goes a long way, teaching goes a long way, creating an interest goes a long way, taking them along with us, treating them as part of our team. They are not there to, may it be a sister, may it be a nurse, may it be an Asha, may it be an A&M. They are not there to aid us, but they are there with us to help us to work together. So that will go a long way. Sometimes these online education programs are not that effective as in person, but they are the second best, where you want to use you want a large group of people at a given point of time. They are the second best, definitely.
Work with what you have.
Thank you for those valuable insights, Dr. Ratnamala. We've spoken about awareness, early detection, and the potential of technology, but translating these into impact at scale requires strong community engagement and local partnerships. And that leads us perfectly to our next question for Dr. Harini. How can initiatives like Suraksha collaborate with large community networks such as the Rotary to strengthen awareness, screening, and early detection of preeclampsia at the grassroots levels?
Good afternoon, Dr. Sangeeta, and a very good afternoon to each and everyone on this platform. First, I would like to extend my heartfelt thank you to Dr. Prakash and his team. I think it was a godsend boon that I met him on the right time, and that is where he spoke to me about Suraksha. And just then, I was being nominated as a district governor for Rotary 3191, and this gave me a beautiful opportunity to inculcate this in my plans of what to do during my governorship. First and foremost, let me give you all a brief introduction of what is Rotary. Rotary is an international organization where we have 1.8 million Rotarians all around the world. So having this sort of a networking, I think we can be your foot soldiers, because as doctors, you have put forward the problems addressed by the mothers and the family, and I've been hearing to you all to this entire program. What I could understand is you have kept everything on the table, but how are we going to talk about this is where Rotary will step in. One is we will go around and help you all by communicating with each and everyone that what is this and what can be done. And the awareness program, we can very largely be a part of it. And just now, doctor was talking about BP apparatus. This is a small example. This apparatus can definitely be given from Rotary side because we are associated with many CSR fundings. So this is not going to be a problem for us. Wherever you say there is some economical need needed, definitely Rotary is there. And more than that, we have a networking of people working all around the clock. So we are there to do whatever help you want in the form of awareness and sometimes even for stepping in economically. This is my answer to you, Dr. Sangeeta.
Thank you so much for that.
Yeah. So we're really happy to be collaborating with the Rotary as well and looking forward to whatever there is to come. So this reminds us again, there's a lasting impact that happens when communities become active partners in maternal health. And that naturally brings me to my next question. Pregnancy care does not begin and end in the hospital. So how can community organizations and support networks play a stronger role in supporting pregnant women throughout their journey, especially those at risk?
Okay. First and foremost, once again, a personal thank you to you, Aishwarya. You have been one of a motivational aspect for this Suraksha. I was very happy to talk to you, and you also encouraged me to think a lot in this aspect. Coming back to the subject, we were talking how. Now we were discussing about like telewise you will come, or you'll come in the form of mobile to give information awareness. See, in Rotary, we have a structure. I think you people know that in the world, polio was eradicated by one and only Rotary. So we have a systematic approach to this sort of issues. I would say that we have something called as road tractors. Who are road tractors? Road tractors are below the age of 30. So what we do is we bring them together and make them give performances, street play, Bidi Natka antivalla, like the street play. So the concept or the subject of this will be that they will go to wherever is needed and they'll give a street play about this awareness. Because what happens is sometimes somewhere when you do it practically, only people will get the idea of what we are talking. So this is one aspect where we can give. And we do have people, we have doctors, surgeons in our Rotary community who will come forward and who will work for this and give this idea or this purpose of Suraksha to each and everyone, whichever platform is available. This is how we can do it, for what question you asked, Aishwarya.
Thank you so much, Doctor.
Yeah.
So, based on your vast experience with the Rotary, how do you think that you can better educate? Because oftentimes the clinical problem doesn't start at the clinic, it started at home. So, how do you think that we can educate danger signs early and encourage timely medical care? As Dr. Ratnamala said, the husband and the mother-in-law are at the seat of decision making. So, how do you think that we can
My
do that?
penny for this thoughts is, see, I would like to like menstruation. That was a taboo at a time where we could not talk about it, especially the girls and with the boys. But I feel catching them young is the solution for this. College students, degree students have to be educated about this. It is not that they're married, or it's not that they're pregnant, but it should become an awareness which comes in a very young stage of their life, so that even when they go home, they discuss with the mothers, they discuss with their fathers, they discuss with their sisters. So what happens? The mother knows what's going to happen in the future. The girl herself knows what's going to happen in the future, and this will give a platform for her to discuss this with her would-be husband or would-be in-laws. It's not going to be a taboo anymore, and they know that, oh, my sweet feet is swollen today, that is because of that. Because a classical example is my own daughter, who's 32 years old. She got pregnant, and when her legs were swollen, we all thought this is part of pregnancy. But I'm telling you, me being a doctor, sometimes we take things for granted. So I feel you have to catch them young. You should start educating about this, how we educate on the other medical aspects. This also should become an education, because this problem we are not addressing for today. We are going to address it for the future years and future generations to come. So I only believe in one factor, that is catch them young. And mother-in-laws, yes, definitely, they also have to be addressed, because at a time they were also young women, but there was no one there to tell them that this sort of things happen. Like as you said, it gets brushed away, saying this is okay, this is how it is, this happened to me, this happened to this. No, very strongly we have to talk, and the medium of talk, the different medium of talks which can be done. And this is where Rotary is an expert in this, and I can put on records that we can bring a very big radical change when Rotary is involved in this. Because you all know polio drops was a stigma at a point of time. There were few communities which refused to take polio drops, saying that it was against their beliefs. But today, we were able to eradicate that same community region. 100% is free of polio. So we do have a strategic planning of how to go about it. Maybe in a in a bigger platform, I can give you with visions, and I can give you with a past history, how Rotary can help you all in this aspect.
That's wonderful. Thank you so much, Dr. Harni. And that was a very, very important reminder that awareness often begins at home. So, as we begin to bring this discussion to an end, I'd like to put across a question to all of the panelists to leave our audience with one final thought. So, if every pregnant woman and family listening today could remember just one thing about preeclampsia from each of your perspectives, what would you want that message to be?
To the public, probably follow your body, follow your instincts. If you're an antenatal patient, please go do those visits correctly so that the doctors can pick up a problem and treat it effectively. Do not miss antenatal visits. And for the doctors, I think should follow the gestosis score, should keep yourself abreast of the latest, use the biomarkers to the extent that you can. And if maybe in collaboration with the Rotary and some tech experts, if you can develop an app which the ASHA workers can use so that automatic alerts to the higher centers can be done as and when BPs go up or any other symptoms come up, and inform the ambulances. I mean, if we can develop an app like that, I think that would go a long way in preventing problems.
It's on the pipeline, so. Yeah.
Sorry?
That's on the pipeline. So
It's in the pipeline, Dr. Gayatri. We are having a big discussion about this particular app. So I'm sure something of that will also come out.
Fantastic.
Dr. Ratnamala, Dr. Harni, any last thoughts?
Awareness and education. Awareness and education is the key.
From my end, I think we have started to abuse YouTubes. We have started to abuse using WhatsApp for all the wrong reasons, especially ChatGPT. See, maybe the information given there is correct, but do you have the capacity to understand what information is being given? This is something which we have to bring to the awareness of all the people, because being a doctor, when I say something, my patients contradict to me saying that no, because they have more belief in the YouTube than what I'm talking. So that awareness should come that this is what is meant to make our life easy, but somewhere we are going the long way that it's making us miserable. So everything you hear, everything you see is not the reality. You have to trust your doctors. You should know to reach out to your doctors immediately and not delaying it. These days, more than grandmothers and mother-in-laws, sorry to say, these sort of communications have become more dangerous. This is my 2 bit of knowledge.
Thank you so much to all our panelists for all of those very thoughtful reflections and powerful take-home messages. So while today's discussion brought together perspectives from across our communities and health systems, preeclampsia is a global challenge that calls for shared learning and a collective action. So we're therefore honored to now hear from our international representative joining us with special messages. So the first is from our representative in Ghana, Ms. Koiwa.
Aishwarya, before we actually start that, I also want to summarize that I think what SMFMI wants to show the world is maybe start with looking at a village as a point, or if with the collaborations of FPAI and Rotary and all the providers as well as the patients, looking at empowering them from measuring BP to maybe use the POC, right? The point of care test, and making it happen, connecting them just not to the PHC, but also the district health hospitals, and also timely education, which is kind of tele education initiative driven. So this is what we want to do on a small pilot project mode, which we probably could be extrapolating it from the PENA education going beyond the providers and maybe use it for the rest of the country as well.
Yeah, Revati, not just rest of the country. We are already being called by South America, Africa, the rest of Asia. So much bigger.
The providers has got the momentum, so we want to do it to the patients as well and
Patients
integrate
also.
both, because ultimately care is comprehensive and it does not differentiate necessarily between providers and patients. So it's education for both with empowerment.
Hello. Greetings from Ghana. My name is Koiwa Koilabi, and I'm happy to be here with you on this World Preeclampsia Day and in this meeting. Thank you, SFMI India and PEN India, for extending an invitation to me. Apologies for not being able to participate in this live session. My name is Koiwa Koilabi. I'm a 4-time survivor of hypertensive disorders of pregnancy. Out of 4 pregnancies, I've lost 3 babies. I have 1 surviving child. And that was because I patronized quality healthcare in a high-income country, specifically United States. 2 of these babies, one of these babies died in my womb. And the only picture of any of the babies who passed is baby Grace. Baby Grace was the last born. There was so much hope. But ignorance killed my other babies in the first one, and then the rest I would blame it on the system. So I always conclude and say that Africa has not given me my baby, Ghana has not given me my baby. So at APEC Ghana, it was out of this that I began to found this organization. After my third experience, when I was trying to seek help, I realized that there was none of this in Ghana. And so inspired by Australia Action on Preeclampsia Ghana, we decided to also form this. And so at APEC, we are driven by the human cost, the stories, the why of the patient's experiences to address the impact, the societal impact, the personal impact of the conditions on family, to connect clinical researchers with real-world patients and experiences, and to ensure that research agenda, any interventions are fueled by the survivors themselves who have either lived or also by those who may have lost a baby, among many others. And so, what is your why? As you continue with this meeting, ask yourself, why am I even part of this? What is the reason why I'm here at this meeting? And what is the why of the profession that I am pursuing? Who we are, APEC Ghana, maternal health NGO focused on hypertensive disorders of pregnancy. We have a structure, as you see here. These are the executive directors, the executive council members. All of them are survivors, from an immunologist to a senior lecturer in molecular medicine and then to a nutritionist. It just tells you that preeclampsia is a respecter of no person, rich or poor, irrespective of our condition. And so at APEC Ghana, this is our mission and our core objective: transforming the landscape of hypertensive disorders through a multifaceted approach: advocacy, research, support, and education. What have we been up to? It started as a WhatsApp group, one of the presentations I did on radio, my first presentation actually. And then it became like people started contacting me, the women who had symptoms. They were like, oh, so when I had this disease, this is what it was. And so it started as a WhatsApp group and social media platform where we utilized Facebook, became a legally registered NGO 1 year on. You see some of these comments and questions here, and I share this with their consent. Some wanted to know that they've been having rising BP. They have had early onset gestational hypertension. What do they do? How could preeclampsia in the first pregnancy have resulted in their gestational diabetes in the other one? Some also said their pregnancy is yet to see, their marriage is yet to have a baby. What should they do? In terms of projects and programs, this is what we do in simple terms: community engagement endeavors, both at the community ground itself, that's through local communities, and also working with the antenatal clinic where we reach our pregnant women. Then there's the stakeholder engagement with our partners, local partners, global partners, national partners, regional partners. The Knowledge Cafe, which is a virtual education platform, scientific symposium, the physical gathering of healthcare practitioners, policymakers, academicians, researchers, patients once a year to be able to discuss updates on management of HDP. And then we partner with researchers to develop interventions to deal with the menace of preeclampsia, an age-related condition, and then counseling and support. In terms of the strategic pillars, we are driven. This is what it is: community engagement. We do it building on trust, working through traditional leaders, local leaders, and also regulators. Knowledge sharing, hosting the APEC Academy and APEC Knowledge Cafes and Scientific Symposium fulfills this. Professional development, all our programs are CPD accredited. Stakeholder collaboration when it comes to developing interventions roadmap, among many others. Scientific contributions, we've been able to, through the symposium, at the end of every symposium, publish manuscripts about the proceedings and publish it in local and international journals. And we've also partnered with researchers, among many others. And so our growth in terms of best practices, that we do now and future is a multifaceted approach. APEC Ghana style is multifaceted, and it's about building sustainable relationship because this is a work that will continue. This is a work that is long term. It's about building capacity of those who are providing the care and even those within the team, developing scalable models and intervention, having into consideration our context and what we have, and then evidence-led advocacy. It is about data for action. Now, in terms of research, we had our own research that we initiated in partnership with the University of Utrecht, Netherlands, developing a priority research agenda for Ghana, which is influenced by the voices of patients, majority, and a few carers and clinicians. So this PSP was guided by the James Lind Alliance framework and then the Research for Health Justice. And it was patient-centered, it was collaborative, it was mutually beneficial, and had a national impact. Most of the time, these research priorities are developed or determined by funders, but these were determined by the patients and their carers. So this is what you see in pictures in terms of how it all went about in administering the question, both in person and long term, in person and online. And we had Dutch volunteers who came to lead and co-lead this project. These are some of the feedback from those who participate. One who said she felt truly equal, that she was on the same table to have her voice heard and make these sort of determinations with doctors and clinicians. And then there was the other who said she was happy to learn that she wasn't alone and she can be part of finding the solution. Other programs, which is what I've earlier shared, but this is just in pictures. This is the APEC Academy in pictures, which happens before the symposium, which usually happens in May in commemoration of World Preeclampsia Awareness Month. This is the symposium itself. We've actually had our 7th symposium, and that was held in the University of Cape Coast, where we bring researchers, policymakers, traditional leaders, students, among many others, to discuss updates on management of HCP, prevention strategies, among many others. In doing so, as I said, we contribute to the academic and to the knowledge base on international publications and local ones as well as the popular platforms where most pregnant women read, and that's our graphics, among many others. This is the Apex Knowledge Cafe in pictures, some of the topics we've explored: risk communication, shared decision making, and then also respectful maternal care. Community engagement in pictures always starts with community entry, initiating, nurturing, and sustaining a desirable relationship. Community is everything. It is not just about those who live in a particular geographic area, it's about those who also have shared interest in a matter. And in doing that, we are guided by the CIOMS guideline on how to engage our communities. Stakeholder engagement in person, where we did our regional tour, and we've been able to tour up to about 5 regions, and where we engage certain key stakeholders, including the director or the health directorate in that particular region. Stakeholder engagement held virtually, where we've explored topics with partners, regulators on religion as a social determinant of maternal health. The proceedings of this is being converted into a manuscript and should be out soon. We also engage audience through newsletter 21st is being published, and then there we highlight the research spotlight, what research is being conducted in Africa related to HCP, the midwifery spotlight, clinician spotlight, and then also the doctor spotlight and the survivor stories, as well as programs and projects. This is the antenatal engagement in pictures, where we work together with the facility to conduct their pregnancy school and also the antenatal clinic, starting with a story sharing. And then mental health. We come from a context where we expected to smile during the day and cry at night. We are trained, or we are raised up to be toughen up. But we are saying it is okay for pregnant women and the family to seek help when they are traumatized by the diagnosis, or even post-trauma when there's been some losses or not, or the birthing experience was very difficult. And this involved the mental health of our partners who support their wife and mothers, that is, their husbands and their partners, among many others. We are also on traditional media, radio, TV. We are everywhere. As indicated, it is a multifaceted approach. And we also published and produced our first preeclampsia diaries in 2022. I encourage all of us to visit YouTube, search this, and you'll be able to hear the stories of fast surviving women, and you'll be amazed. The story of one woman who has been pregnant 3 times, never heard of preeclampsia until her fourth pregnancy when she was diagnosed. So the question will be, when should the education on preeclampsia and other pregnancy complications start? Should it be just targeted at those at risk and diagnosed, or it should be part of the general routine of education during antenatal? Then we had also some interns who came to express these stories in arts, and we display this art in many ways because art is a powerful form of expression, healing, and awareness. Global engagements, we've been everywhere. Not everywhere, but we try to be where we can be. International Maternal Newborn Health Conference 23 and 26, we had the platform to even share our story as part of the preliminary open. European Global Conference, and even the recent Global Preeclampsia Summit, which was held in Kigali, Rwanda. We were represented there, and the lived experience patient voices was there. Our reach over 2,000 members in our newsletter, WhatsApp, and about 500 member plus, and then also through the healthcare practitioners scientific symposium and 10 regional coordinators. Finally, if you're thinking of getting in touch, we'd love to hear from you. We are happy to share that APEC Ghana is currently the host of the Africa Preeclampsia Network, which is a patient-led organization by organizations in Tanzania, Kenya, Cameroon, among others, and also other researchers in high-income countries who are conducting research on the African continent. The goal is to synergize the collaboration, build the partnership, and then also drive the changes with patient voices. Thank you very much for listening. And this is Dioli, my daughter, the one who is who survived out of the lots. Thank you.
I think those were some amazing ideas from Ms. Koiwa that we ourselves could use for our advocacy programs. And I sincerely thank all our panelists for sharing your time, expertise, and perspectives so generously today. But some of the most powerful lessons come from women who've lived through this journey themselves. So, transitioning to the patient perspective, we'll be transitioning to the patient perspective. So, subscribe to VLSP programs if you want to watch more on different advocacy groups from around the world. Now we're so very deeply grateful to share a special pre-recorded message from one of our preeclampsia survivors who graciously chosen to share her experience, not only to tell her story, but to help raise awareness and remind everyone that they're not alone. Also, just wanted to make a small announcement. In case there are any glitches in your video, please rejoin using the same link. So can we have
Rosalie is just trying to see if she can extend time. Otherwise, we rejoin.
Sure. First and foremost, I'd like to thank you so much for joining us today on World Preeclampsia Day to talk about something that's very personal to you in order to help other women who face the same through our program Suraksha. The reason we created Suraksha was so that women can help each other, because it's not just clinical support from your doctors, but also moral and emotional support that other women are also by your side through this whole process, and that really makes the difference. So thank you once again for sharing your journey with us. We do have a few questions about it that we'd like you to answer to the extent possible. So shall we begin?
Yes, ma'am.
Okay. So as a mother with an advanced age, diagnosed with preeclampsia, could you share your pregnancy journey and the challenges that you faced during this experience?
Yes, ma'am. My pregnancy journey was mixed emotions, challenging, physically considered high risk. And when I was diagnosed with preeclampsia, it created a lot of fear and uncertainty for me and my family. There were days filled with anxiety about my blood pressure, my baby's growth, and the possibility of complications. Frequent hospital visits, investigations, and the fear of preterm delivery were overwhelming at times. I have delivered the baby at the week of 30. So it is not that easy to go ahead for preterm delivery, because considering my biomarker values, it was like up and down anytime we see. So we thought to go ahead about this. So before going ahead to the delivery, we thought like my doctor had told me multiple tests like giving steroid injections for a baby's lungs maturity and for baby's brain safety. Many tests and many medications that we have undergone to get our baby safely outside and to give to the neonatologist. So once we have delivered the healthy baby, we have sent her to NICU without ventilator. So she was there up to required weeks, and she was healthy there without ventilator. So with this constant support from my doctor and my family members, we stayed hopeful and focused on doing everything possible to ensure the safety of my babies and myself.
I'm so happy to hear that. And congratulations on a wonderful outcome. But I can completely understand that it wasn't so easy going through the whole process. But as you mentioned, you underwent biomarker based surveillance during your pregnancy. How did this monitoring help you and your clinical team make timely decisions that ultimately contributed to a safe delivery for you as well as your baby?
Biomarker-based surveillance played very important role in my pregnancy care. It helped the medical team closely monitoring the progression of my preeclampsia and understand how my condition was changing over time. The result guided timely clinical decisions regarding medications, monitoring frequency, hospitalizations, and the safety timings for delivery. Because of this close surveillance, my doctors were able to intervene early, like before serious complication developed, which ultimately helped achieve a safe delivery and for safe delivery for both me and my baby. I truly believe this proactive monitoring made a significant differences in my pregnancy outcome.
It's really wonderful how positive you were through this whole thing, and that really makes a huge difference. But I do want to ask, biomarker surveillance, I'm sure, was a relatively new concept for you and your family. So how did the counseling and guidance provided by your maternal fetal medicine specialist and their team help you understand and accept this surveillance process?
Yeah. Initially, biomarker surveillance was something completely new and unfamiliar to us. We are unaware about this, and naturally, we had many doubts and concerns. So, the maternal fetal medicine specialist and the entire team patiently explained the purpose of each test, how it would be help assess the disease progressions and why it was important for both maternal and fetal safety. Their counseling gave us clarity and confidence. They answered every questions with compassion and made us feel involved in the decision making process. Over time, this guidance helped us trust the process and understand these surveillance methods were helping provide the best possible care of my pregnancy.
It's truly amazing how well you grasped this and understood and accepted this. So, I know that you had a whole team with you, a maternal fetal medicine specialist, a physician, imaging expert, hematologist, neonatologist, geneticist, nutritionist, lifestyle consultants, and support staff. So, how did the coordinated care from this entire multidisciplinary team help you feel supported and prepared throughout your pregnancy and delivery?
Yeah, the coordinated care from the multidisciplinary team gave me immense reassurance throughout my pregnancy journey. Every specialist contribute their expertise to monitor and manage different aspects of my condition. My fetal, like my MFM specialist carefully guided the pregnancy. The physician managed my medical condition. The geneticist managed about mine and my baby's growth. The radiologist expert monitored my baby's growth and well-being, and the neonatologist prepared us to for a possible preterm care needs. The nutritionist, dietitian consult us also helped me making healthier choices during a stressful time. So most importantly, the team communicated with each other seamlessly, which made me feel safe. The team communicated with like made me feel safe, supported, and confident that I was receiving comprehensive care. Their compassion and teamwork reduced a lot out of reduced a lot out of fear and uncertainty from my mind.
That gives everyone here such a positive message. I think working with a multidisciplinary team and going through this with everyone is the best thing for a good outcome. So, having successfully navigated this journey and now serving as an ambassador for biomarker based surveillance in preeclampsia, what message would you like to share with mothers who are currently battling preeclampsia or have experienced this in a previous pregnancy?
Yeah. My message to mothers who are facing this preeclampsia is to never lose hope and to trust your medical team. Preeclampsia can be frightening, but early diagnosis, regular monitoring, and timely intervention can make a huge difference in outcome. I'm the best example for this. And for both mother and baby, whatever the medical team is assessing, they should blindly follow them. The biomarker based surveillance gave my doctors valuable information that helped me guide my care safely, and I encourage mothers to stay informed and actively participate in their treatment journey. So most importantly, seek support. Ask questions without hesitations, and remember that with the right care and guidance, it is possible to overcome this difficult journey successfully. I remain deeply grateful to my doctor and healthcare team for helping bring my baby safely into this world.
Thank you so much for such a beautiful message to all the women watching here today. I'm sure you will motivate and inspire so many women to truly understand preeclampsia and know that it is manageable and good outcomes are possible with the right kind of help. So, with that, we come to the end of our questions, and that was a wonderful chat. And I sincerely thank you again from the bottom of my heart for sparing time to do this. People like you are the reason that we can help many more women and give them the same good outcomes as you. So, thank you so much once again.
Thank you so much for this opportunity, and I'm really grateful to my doctor who has stood out my side and yet meaningful journey he started through her. That's why. Thank you so much, and I'm wishing all other mothers to assess the medical team. Assess the medical team who positively, and they also can deliver the healthy baby like mine, and they can live their life purposefully. Thank you so much for this opportunity.
Thank you so much.
Thank you.
That was a truly heartwarming and deeply moving reminder that behind every discussion on preeclampsia are real journeys, real challenges, and real strength. So, we next have a very wonderfully curated message from our representatives from Australia, Dr. Anne-Marie Hennessy and Ms. Amanda Davidson.
Hello everyone, I'm Amanda Davidson and I'm a director of the Australian Pregnancy Hypertension Foundation Limited here in Australia. I'm here with Professor Anne-Marie Hennessy, who's also a director of the foundation, and we've been invited to do a short presentation to you all on by PENI, the Preeclampsia Education of the Nations organisation in India, on what we're doing here in Australia on for preeclampsia research. I just wanted to open by saying thank you very much for this invitation. We're really pleased to have been invited to prepare this short presentation and to talk to you about what we're doing here in Australia. Just by way of general background, we set up the foundation, AFL, about 25 years ago after I had preeclampsia when I was pregnant with my son, Harry, who's turning 25 this year. I was lucky enough to be treated by Professor Hennessy, who was my doctor at the time. After having had preeclampsia and having not heard of what preeclampsia was all about before I had it myself, I discussed the issue with Professor Hennessy and some other doctors at the time, and decided to establish what was then called PEARLS, an organisation to raise funds for supporting research into preeclampsia. We've been supporting that research now for 25 years, and in 2023 we set up a standalone charity under the banner AFL. Anne-Marie's here today to talk about the sorts of research that we have been supporting over that 25-year period, and some of the results that we're proud to have been involved with. And later on, after Anne-Marie's talked about that, I'll come back to talk a little bit about what we're doing for preeclampsia, World Preeclampsia Day, and the things that we've got marked for our future fundraising efforts.
Thanks, Amanda. So we did meet when I was caring for Amanda at the time, and in my 25 or 30 years of clinical practice in Sydney, I've cared for over 10,000 women with preeclampsia. Some of the research work that's been able to be funded by Amanda and her team have included supporting our placenta bank. So women have donated their placentas, and that has allowed us to look at everything from the kind of abnormal proteins and toxins that might be coming from a placenta, but also what's the impact of the medications that we might use for blood pressure, and ways that we could potentially treat those things that are going wrong with the placenta that we can pick up from that work. Some of that work had led us to do clinical trials, and our most recent clinical trial was completed in Malawi in Central Africa. That work was looking to prevent the consequences of preeclampsia using calcium and aspirin in a design that's recently been published. But more importantly, that meant that community focused strongly on what might be the risk factors for preeclampsia and how that might be prevented or treated. That has also led to ongoing work that's been funded by a large consortium, including our colleagues in the United States of America. And the most recent trial has been in Malawi and in India. So that we thought gave us full circle to be able to come and talk to you today about what we're doing. I'll hand back to Amanda, because some of that work has led to her involvement in the development of national guidelines here in Australia.
That's right. And I was really excited when I was invited by the team here in Australia working under the SOMANS to prepare the guidelines on how to manage and treat preeclampsia. I think I was one of about 45 people on the team that were recruited to do that work, and I think the only non-medically qualified person. So my involvement was very much from a consumer perspective. When I talk about a consumer, the patient perspective, and seeing what the guidelines were talking about, and the recommendations that were being made, and how they were translatable into day-to-day practice, and also into just generally being understood by patients who are facing this condition during their pregnancies, which can often be a really, really difficult time. So the guidelines, I thought, was a fantastic project. It resulted in an amazing publication, which I think is very, very widely read, and I think is a very useful document for the purposes of doctors and medical teams treating women with preeclampsia, but also for women themselves in understanding that this condition and what they can do to help manage the problem themselves during their pregnancies. So I'm really grateful and proud of my involvement in the SOMANS guidelines, and I can see now how important such guidelines are internationally in terms of clinical practice and for patients' understanding. I think that what would be a fantastic idea is if we could get a single guideline around the world that everyone could agree to. I know there's a lot of disagreement between doctors in terms of the different guidelines, and I do understand that there are different factors that come into play in different countries, but it would be great if we could have a single guideline, I think, from a patient's perspective.
Yeah, thanks, Amanda. And look, that has led to us being able to work with other guideline developers, and I'm on some international teams doing that at the moment. One of the things that struck us, and again, this has been in conversation particularly with Amanda, has been how trusted the sources of information are that give us the information for a guideline. And Amanda would love, and I agree, having that information being able to be interrogated carefully by the patients and by the specialists. And we have this dream of having a preeclampsia specific pregnancy safe guidebook in the form of an app that would be on everyone's phone. And we're investing in some work to make that happen. If we had a canon of information that was relevant to preeclampsia, then a pregnancy canon might give us better trusted information than some of the random, I'm going to say it, but random rubbish that you read on the web when you've got an unguided approach to finding these things out. One of the things that I love about the SOMANS, which is the Society for Obstetric Medicine in Australia and New Zealand, and one of the things I love about that guideline is that it doesn't treat these issues as an on-off switch. Calcium or no calcium, aspirin or no aspirin. These are actually, while they might be cheap and weak for prevention, these cheap and strategies that might be easy to use, they need to be nuanced and they need to be safe. They need to be available, affordable, accessible, and be efficient and successful in the things that they're trying to tell us about what is in pregnancy. And I might just draw your attention to the calcium guidelines, where we might assess risk based on a number of risk factors, such as whether your mum had preeclampsia, whether your age, perhaps whether you've got diabetes or not, for example, or whether you've already got blood pressure issues that might lead to you getting preeclampsia. But it actually includes an assessment of what your dietary calcium is. There's a calcium calculator in the guidelines. So it's telling everyone that there's maybe a simple treatment, but it needs to be adopted in a thoughtful fashion, and the complexities of those kinds of treatments need to be carefully thought through. And we need to be clear what we are advising women about in terms of whether these strategies are likely to work and to work everywhere around the world. So, watch this space. This time next year, we hope to tell you about how our app development is going. And I'll hand back to Amanda now to finish up. She's going to tell you what we're doing in Australia for World Preeclampsia Day.
We are going to be doing a couple of things for World Preeclampsia Day to mark that day. Firstly, we're holding a free webinar, which has been we've invited quite a number of, probably a couple of thousand women to come along to that. I don't think we'll get a couple of thousand women, but we're hoping to get a really good attendance because we've advertised it very well. And Professor Hennessy is going to be presenting on the latest things that are being looked at in terms of preeclampsia research and the dissemination of information. The app that Anne-Marie was just talking about is one of those things, and we're very, very keen to put some more funding into the development of that app and to get that rolled out. We see that as being something that could be actually used internationally. There are a number of other things that are being looked at as well that Anne-Marie is going to be talking about, including blood tests and other predictive methods of looking at how who is likely to get preeclampsia. And then the other thing that we are doing for World Preeclampsia Day is an event which is, again, it's a dissemination of information, but it's a fundraiser that will be held here in Sydney, where we're inviting people to come along and again listen to Professor Hennessy. But we're also lucky enough to have coming to Australia, and we're really proud of this, Memory Nagira, who is the PhD student that has just graduated. She's coming to Australia to get her degree. AFL and Pearls have been involved in supporting her through her PhD, as is Professor Hennessy. And she'll be here in Australia, and she's going to be speaking to us about her research and the results of her research here in Sydney on the 12th of June. So we're looking forward to that event.
All right, so we can wish you a thoughtful Preeclampsia Day, and we live for the day when it's gone. So
Absolutely.
Keep up all the great work in education, and we admire the work that Penna is doing across the whole of the subcontinent in India. So thank you for the great work and have a great day.
Thanks and bye.
Bye.
Thank you for that message. Next, we have a very informative message from the CEO of the Preeclampsia Foundation, Ms. Eleni Segas.
Hello, everybody. I'm Eleni Tsigas. I'm the CEO of the Preeclampsia Foundation, and I am honored to have been asked to share some remarks with this esteemed group of leaders and providers and patients in India who are working to really change the course of preeclampsia and eclampsia in your country. I by no means have the secret sauce to what makes a successful patient advocacy organization, but as I know you all are working to strengthen the voices and the impact of patients in your country, I thought I would just offer a few ideas from our work. We are a 25-year-old organization. I've been at the helm for about 18 years, and I feel like we've learned a few things along the way. So I'll start with this comment. Doing this work is a marathon, not a sprint. It really does require being in it for the long term because there are no quick fixes to this problem. And our role as patient advocates really needs to be a role of commitment and enduring commitment. So some of the implications of this framing of this work being a marathon, not a sprint, includes how we view ourselves and how we conduct ourselves. There's a difference between being an activist and being an advocate, and they're both disruptors and they're both needed to change the course of the work that we're doing. They both require skills of persuasion. But here's how I look at the difference. An activist, number one, it needs a lot of people, and they're the ones who are standing in front of the building trying to get the attention of the decision makers with placards, with picketing, with marches, with making a lot of noise and being disruptive to the status quo. The modern day equivalent of that may be what we call keyboard warriors, people who are on social media and jumping onto comments, making comments, trying to sort of rile up the status quo. An advocate, on the other hand, is not standing in front of the building with the picket signs. The advocate takes a more thoughtful, long view of the problem and is collaborative, is respectful, is respected, and is invited into the building to sit at the table where discussions and decisions are happening. This does take a longer view. It does not mean that you're not still true to your point of view as somebody with lived experience, but it does require that sense of thoughtfulness and collaboration so that you are at the table for the long term. Lasting impact happens when you are an effective advocate. The other component of this being a marathon, not a sprint, is that it's all about partnerships. As patient advocates, we cannot do this alone. As the expression says, if you want to go fast, go alone. If you want to go farther, go together. And in that spirit, we need our partnerships with government, policymakers, sometimes financial resources, federal or national or local agencies. We need partnerships with professional societies, recognizing that it is the professionals who are developing the guidelines, but they can't develop them. They shouldn't develop them without our voice being part of that process. Researchers are sometimes part of professional societies or part of independent societies. And finally, the media. The media in any country, whether it's a free media or a government-controlled media, often is the place where the court of public opinion is made and proclaimed. Hopefully you're working with credible media, you're identifying who the real influencers are. We are always learning, we are always persuading, we are always making sure that our voice is in all of those partnerships that I just mentioned. Now, the key is that your message stays consistent regardless of who you're talking to. But the specific thread that you're pulling on, the specific angle that you're taking with what you're trying to achieve has to be adaptive to what that audience needs and what is serving their purposes. So this is important. It requires really being smart and strategic. Your politicians, your political leaders may change from time to time. Here in the United States, we have parties that change, and whatever party is in office in this 4-year cycle is not necessarily going to be the party in office in the next 4-year cycle. We have to remain central, we have to remain collaborative, and we have to be able to work with whoever is in office. And that means that we maintain our moral authority as patients, but we recognize that the specific angle that we're taking to try to achieve our goals is going to slightly change depending on who we're talking to. The strategies that you take as advocates, as patient advocates, is going to change depending on the depth and the length of commitment that you have. My analogy of a marathon, not a sprint. In the short term, when you might still have the energy to be doing the sprinting, your short but limited energy needs to be expended to educate and support families, to educate allied healthcare providers, or partner with professional societies to do so. Tell those stories of lived experience. Tell them to the media. Tell them to anybody who will listen. Host community events. Build a community following. Use the drama and emotion of a few compelling stories to really drive home the impact of preeclampsia. The key is using not just the stories, though, but also strong evidence in those stories, in those narratives, because you want somebody listening to the story to not just have their heart engaged, but also to have their mind engaged. They need to understand that the story they're hearing, compelling though it is representative of a larger story, and the data will help support the fact that it is a larger story. When you have more resources, when you're in this for a longer time and you're looking for a deeper impact, then you're going to go beyond some of those strategies to become the go-to resource for government and media, regardless, as I said earlier, regardless of who's in office, regardless of who's in power. Your efforts are going to be limited and strategic in focus. You're not going to try to be all things to all people. Look for ways to develop scalable programs that impact health outcomes. Here in the US, one example of that is we have developed a distribution program for home blood pressure monitors. We've developed a program that is supported by multiple funders. And at this point, we have distributed over 70,000 cuff kits. They include not just the blood pressure measuring device, but special education material that ensures that the patient, the woman, knows how to take her blood pressure correctly and is able to communicate this to her healthcare providers. So that's been a very impactful, scalable program for us. We've now worked with over 700 providers, actually more closer to 900 providers. And as I said, we've distributed probably over 70,000 of these kits already. You're also looking, once you're more established, you're looking at not just repeating information, as one of my signs says in my office, be a voice, not an echo. And sometimes that means that you are regurgitating and relaying information that others have created. But as you mature as an advocate, as an advocacy organization, you're creating data. And I don't mean you're creating out of thin air. I mean, you're collecting data, you're analyzing it, and you are distributing it as a source of information, conveying new perspectives, new data sources, and accountability. So one of the things that patient advocacy organizations really do well is holding their officials, their providers, and others in positions of power, holding them accountable to their metrics. These kinds of activities, again, supported by partnerships. We rarely do this alone. We also have the unique ability to be agnostic. And what I mean by that is we're not beholden to any one particular company, manufacturer, pharmaceutical company, diagnostic company. We step back from those individual efforts as well as the individual efforts of specific researchers. We're also not just lining up behind one particular researcher. And by maintaining this agnostic position, we can be the big tent for all comers. We can be the voice that convenes the other players to think about how do we move, as we say, a rising tide floats all boats. If we can lift up the space, there is room then for lifting all those individual players up with us. So think about, how do you function as a big tent? How do you function as a convener? How do you identify where the missing pieces of information are? I'll give you one example, and then I'm going to close. For many years, even here in the United States, we really did not know what the economic burden of preeclampsia was. There had been no papers written on this. There had been no data collected. And as an organization, we started advocating. We started working through our board members, our trustees, our corporate partners, people in position of influence in the government. And we really started advocating that we needed to find an economist, a business school, somebody who would pick up the mantle of this missing data. We did not know what is the burden, what is the cost of preeclampsia. It takes time to do this. You can do a lot of shouting and a lot of talking and a lot of cajoling and a lot of persuading. And sometimes it takes a long time to identify the resources that are going to accomplish your mission. Once we did, we discovered, and there were publications put out demonstrating that in the US, the short-term cost of preeclampsia, not the long-term, the short-term costs were $2.18 billion per year. Now, I suspect that that is a drop in the bucket, not only in India, but in any low or middle income country where the burden of disease is significantly higher. But once you have a piece of information like that, then you carry that as a credible source of information to news outlets, to media outlets, to others that you are trying to influence, to demonstrate that there actually is an economic cost to the problem that you're trying to solve. There are other angles in thinking about how do you get your story told. There are the stories of national pride or national shame. If your country is stacked up against others in the world and you are doing amongst the worst in saving the lives of mothers and their babies, appealing to political leaders. And really, as I said, it's either a story of political shame and how poorly the country is doing relative to others in the same category, or if progress is being made, celebrate that and collectively demonstrate national pride in actually having made some progress. The important thing that I would say to any advocates working in this space, we always talk about the importance of listening to women's voices. Absolutely. Like, you cannot do this work without listening to women's voices. But I would contend if all you're doing is listening to their voices and not learning from their experiences, then you've missed at least half of the opportunity that comes from engaging patients. You want to understand what has been missing in patient care, whether it's in diagnosis, prevention, treatment, what's happening in the community, what happens before that mother even shows up to the hospital, and what happens when she goes home. All of these touch points are an opportunity to actually learn from patients, take those learnings and build them into the solutions and bundles and progress that you're advocating for. So listening to women's voices, critical, central to what you're doing. But it's not just listening to their stories, it's also listening and learning from those experiences. So I know that's just a very quick snapshot of some of my hopefully motivating comments about why and how to lift up patient voices in your country. I do hope that you are able to take this to heart, and that those of you who have lived experiences like myself and my team, that we continue to draw upon the strength of that experience to remind ourselves and to remind others that we are doing this to help all the mothers and babies of the world. Thank you, and I wish you great success in your endeavors on World Preeclampsia Day and every day.
Thank you. And that was such a wonderful learning that we had and sharing by Mrs. Eleni and Anne-Marie Hennessy and the person from Ghana. And I think we could take a lot of valuable lessons from all of their videos. And we're very, very fortunate to have access to these people who have spoken to us via this, thanks to Dr. Prakash Mehta and Dr. Revati and SMFMI. And we're very grateful to Suraksha. I think the takeaway for any woman who has been following along is that you know that there is access to healthcare. There are a lot of advances in medical science wherever you're at. Now you definitely have AI platforms to reach out to, but I think just knowing basic symptoms, signs and symptoms, meeting your provider on time and getting the attention without having any kind of hesitation is, and if you have any need to reach out to your provider at any time, knowing that you can, and that is one of the first steps. And definitely all the social outreach, the integration with the ASHA workers, our government, our policy changes, with the Rotary, of course, Dr. Harini's suggestions were very valuable. And I'm going to ask Dr. Aishwarya to take over for the vote of thanks.
Thank you for summarizing that beautifully. And just before that, to everyone joining us today, if today's discussion has raised questions for you, or if you would like to further your guidance or related to pregnancy, preeclampsia, or maternal health, we invite you to write to us at guidance@smfmi@gmail.com. We'd be happy to continue the conversation and support for you wherever we can. So, to all our distinguished guests, respected faculty, colleagues, partners, and everyone joining us from all across India and the globe, today's program truly reflected the spirit of Vidya Prabodha, awakening through knowledge. What made today especially meaningful was the remarkable diversity of voices that came together for this initiative from across the world. All came together with one shared purpose: improving awareness and outcomes in maternal health and preeclampsia. So it's truly powerful that even individuals who coordinated and hosted this program, namely Dr. Snehal, Dr. Gayatri, Dr. Sangeeta, and myself, represent different regions in our country, coming together to build one unified platform for education, awareness, and advocacy. We extend our deepest gratitude to all our national and international faculty, panelists, editors, moderators, advocacy representatives, and support groups who so generously took the time out of their demanding schedules and joined us from across different time zones to contribute their expertise and insights to today's program. Our sincerest thanks to Dr. Sadhana Gupta, Dr. Prakash Mehta, Dr. Revati Rajan, Dr. Kenneth Shen, Dr. Ramani Devi, Dr. Bharti Sharma, Dr. Shobha Gudi, Dr. Snehal Kohale, Dr. Gayatri Matrabhutam, Dr. Sangeeta Shivaraman, Dr. Harini Ravindranath, Dr. Gayatri Karthik, Dr. Ratnamala Desai, Ms. Koiwa Koilarbi, Ms. Eleni Tsigas, Dr. Anne-Marie Hennessy, and Ms. Amanda Davidson. Thank you all once again for lending your time, voices, and expertise to this important initiative. Our heartfelt thanks to the Society for Maternal Fetal Medicine India, our President Dr. Prakash Mehta, and Secretary Dr. Revati Rajan for their leadership, encouragement, and guidance throughout. Most importantly, we sincerely thank the preeclampsia survivors and families who courageously shared their journeys and experiences. Your voice brought honesty, humanity, and purpose to today's discussions, and they're central to what Suraksha hopes to achieve. We'd also like to sincerely thank the International Society for the Study of Hypertension in Pregnancy for considering and featuring this program and its access link on its platform, thereby facilitating global visibility and access to these important discussions. A special thank you to the Family Planning Association of India and Rotary International for partnering with us in strengthening patient education, awareness, and grassroots level community engagement. To our audience joining us live and online, thank you for your participation and for helping us carry this conversation beyond the four walls of our room and into communities across the world. A note of gratitude to Mr. Rajagopal and the SMFMI office for their tireless coordination and support behind the scenes. And finally, we sincerely thank Viral Ortho, our knowledge partner, Dr. Shikha Malhotra and Ms. Rosalie, for providing us a platform and support to make this program possible and helping us amplify this message on a global scale. As we close today's event, we hope Suraksha continues to grow as a platform for awareness, education, advocacy, and support, bringing together voices from across disciplines, communities, and countries in the collective pursuit of safer pregnancies and better maternal health outcomes. Thank you all once again, and together, let us continue working towards better maternal health and safer futures for women everywhere. Thank you and have a wonderful day.
As we come to the close of this meaningful session, on behalf of Viral Ortho, we extend our heartfelt
Thank you, everyone, and have a great day.
Thank you, sir.
Thank you all, and let's commit ourselves for preeclampsia care and management.